Hey everyone, good evening. I'm really excited to be here today, to talk about something that's super important to a lot of us, cancer and the different ways we can treat it. Cancer is a major issue. It's the second leading cause of death in the US, causing about a quarter of all deaths. We've seen some amazing progress in treating cancer, and chemotherapy has always been a key part of that. Until recently, we mostly used the maximum tolerated dose method, or MTD. You've probably heard of MTD chemotherapy, in NCCN guidelines, discussions, textbooks, and lectures. It's been the standard. But now, there's this new thing called metronomic low-dose chemotherapy. It's a completely different approach and strategy for treatment. Today, I'm focusing on metronomic low-dose chemotherapy. It's a topic that a lot of doctors aren't too comfortable talking about, simply because it is not part of the so-called standard of care, and some doctors even think it's not worth considering. Let's think about it like this. Now it's Christmas season. A lot of us are going to watch the Nutcracker, which I absolutely love. The first time I saw it in live performance, I was blown away by the amazing performance by the local ice skaters in our small town. I knew people could skate, but seeing it in person really hit me. I couldn't believe how these little kids could do such tough routines on ice, when some of us can't even walk on it. That's kind of like metronomic low-dose chemotherapy. Many of us doctors have never tried using chemotherapy in such low doses, and might not believe it works. I was skeptical too, until I tried it with my first patient. I saw huge tumors just shrink away with just a small dose of an old chemotherapy. This was after the patient had failed several rounds of the standard maximum tolerated dose chemotherapy, or the so-called MTD, and was sent to hospice 3 times. So my message is, don't dismiss it outright. Keep an open mind, and consider using it for some patients who come to you. And for the patients out there, I hope metronomic low-dose chemotherapy becomes an accepted option for everyone in near future, just like MTD chemotherapy. In my presentation, I'll give you all the latest info and insights on metronomic chemotherapy. Stay tuned. Our journey with chemotherapy dates back to the early 20th century, to the year 1942, when it was first discovered by 2 remarkable individuals, Dr. Alfred Gilman and Dr. Louis Goodman, both from Yale School of Medicine. Their groundbreaking work laid the foundation for using drugs like chemotherapy to treat cancer, and their legacy continues to influence cancer therapy today. Traditional chemotherapy, as we know it, relies on something called the maximum tolerated dose, or MTD schedule. It involves administering the highest amount of chemotherapy that a patient can tolerate, given in cycles, with extended intervals. For decades, the standard in cancer treatment has been the use of maximum tolerated dose chemotherapy. This approach remains a fundamental component of most national comprehensive cancer network treatment protocols. The principle underlying MTD chemotherapy is the administration of high-dose cytotoxic agents, with the aim of achieving complete eradication of tumors. Traditionally, this approach has operated on the premise that more is better, when it comes to chemotherapy dosing. However, there's a drawback to this approach. It doesn't distinguish between cancer cells and healthy ones, leading to unwanted side effects. Moreover, during the drug-free periods between cycles, therapy-resistant tumor cells have the chance to regenerate, often causing disease progression. It's a challenging situation, but we've been exploring alternative approaches to improve treatment outcomes and patient experience. Fast forward to the present day, and we find ourselves in an era of targeted therapies and immunotherapy, revolutionizing the way we approach cancer treatment. But chemotherapy remains a crucial part of the toolkit in our fight against this formidable adversary. 60 years after the initial discovery of chemotherapy by Yale doctors, a groundbreaking concept, known as metronomic chemotherapy, or MCT, came to the forefront in the year 2000, introduced by Dr. Folkman, Dr. Broder from Harvard, and Dr. Kerbel from the University of Toronto. MCT marks a pivotal turning point in our comprehension of the mechanisms underlying chemotherapy and its optimal utilization. What sets MCT apart is its utilization of very low doses of chemotherapy, administered continuously, without the extended drug-free intervals commonly associated with traditional high-dose chemotherapy. This sustained, low-dose approach maintains the drug within a patient's system, at a reduced yet still effective concentration, for an extended duration. The result is a therapy that not only combats cancer, but also mitigates adverse effects, and retards the development of drug resistance. Consequently, MCT has translated into reduced hospital admissions, and an overall enhancement in the quality of life for many patients. Remarkably, while cancer patients have embraced this approach with enthusiasm, it has encountered some resistance within the realms of cancer research and medical oncology communities. Nonetheless, a beacon of hope is visible on the horizon. Dr. Eric Winter, chief physician at Yale Cancer Center, has been a vocal proponent of chemotherapy dose-to-escalation. He has laid down guidelines for conducting dose-to-escalation trials in the context of cancer treatment, laying the groundwork for data-driven decision-making. In an interview with Cancer Today magazine, Dr. Eric Winter, a medical oncologist and former chief of the Division of Breast Oncology at the Dana-Farber Cancer Institute in Boston, who now serves as the chief physician at the Yale Cancer Center, expressed his support for the approach of utilizing low-dose chemotherapy. Dr. Winter emphasized the importance of this approach, stating, "Just because you have cancer, and are on treatment, doesn't mean you have to be miserable." He suggested that oncologists might contemplate commencing treatment with a lower dosage, and then adjusting it according to the patient's specific requirements, rather than initiating therapy with the highest dose and subsequently reducing it due to toxicity. In an effort to minimize the adverse side effects associated with cancer treatment, Dr. Winter and his colleagues authored guidelines for conducting studies focused on dose-to-escalation. These guidelines were published in the December 2020 issue of the Journal of Clinical Oncology. The objective of this roadmap is to outline how clinical trials can be more effectively planned and executed to investigate the use of lower drug dosages, without compromising the clinical benefits provided to patients. Today, I am here to provide you with up-to-date information on metronomic chemotherapy in cancer treatment, elucidate its scientific principles, and present clinical data that support the incorporation of MCT into daily practice. As evidence accumulates, and our comprehension of metronomic chemotherapy deepens, we may witness its ascent as a standard of care, potentially supplanting the traditional maximum tolerated dose treatments. This transformation could usher in a new era of more effective, less toxic, and patient-centered cancer therapies. As mentioned earlier, it's essential to emphasize that metronomic chemotherapy, MCT, stands apart from the traditional maximum tolerated dose, or MTD, approach. Now, let's explore the scientific underpinnings of how MCT operates. Angiogenesis inhibition. At the core of metronomic chemotherapy lies its ability to inhibit angiogenesis, the process of forming new blood vessels. In the context of cancer, this pertains to disrupting the formation of blood vessels within tumors. Why is this significant? Well, these blood vessels serve as the lifeline for tumors, supplying them with oxygen and nutrients, essentially fueling their growth. By interrupting this process, we effectively starve the tumors, depriving them of the vital sustenance they require to thrive. Suppression of tumor-promoting inflammation. Another pivotal facet of MCT is its capability to suppress tumor-promoting inflammation. Inflammation plays a substantial role in bolstering tumor growth. Metronomic chemotherapy intervenes by diminishing the signals that propagate this inflammatory environment within the tumor. In doing so, it obstructs the tumor's ability to prosper and disseminate. Enhancement of anti-tumor immune responses. Now, let's shift our focus to how metronomic chemotherapy can fortify our body's innate defenses against cancer. It operates by activating the immune system, motivating it to identify and target cancer cells. This is akin to deploying reinforcements to assist our body in the internal battle against the disease. Tumor microenvironment modification. The tumor microenvironment serves as the epicenter of cancer activity. Metronomic chemotherapy exerts its influence on this environment through several crucial mechanisms. It induces tumor dormancy and senescence, effectively inducing a state where cancer cells become dormant or age prematurely. Additionally, it reduces the heterogeneity of malignant cells, rendering the tumor more susceptible to treatment. Most importantly, it thwarts a process known as epithelial mesenchymal transition, or EMT, a pivotal step in which cancer cells acquire the ability to become invasive and spread to other parts of the body. In essence, metronomic chemotherapy represents a refined approach to cancer treatment. It zeroes in on the very processes that tumors rely on for growth and dissemination, all while minimizing the adverse effects frequently associated with traditional high-dose chemotherapy. This promising approach offers hope for more effective and patient-friendly cancer therapies. Let's begin with a discussion on breast cancer. Clinical experience in the field of breast cancer has highlighted its prominence as one of the key areas for metronomic therapy. The rising number of patients facing incurable metastatic disease, necessitating palliative treatment, coupled with the cumulative toxicity associated with traditional cytotoxic therapies, has prompted a focused effort to explore alternatives to conventional treatment regimens. This includes drugs such as taxanes, anthracyclines, pyrimidine antimetabolites, and tubulin inhibitors. Among the candidates for metronomic therapy, cyclophosphamide and methotrexate have emerged as prominent options in the context of breast cancer. Earlier studies delved into the oral metronomic administration of cyclophosphamide and methotrexate in combination for pre-treated metastatic breast cancer patients. Notably, Colleoni conducted research involving a daily dose of cyclophosphamide at 50 mg along with methotrexate at 2.5 mg twice daily for 2 days per week. This approach yielded an objective response rate of 20.9%, and a clinical benefit rate of 31.7%. In the long-term follow-up, a subset of these patients achieved a prolonged clinical benefit, extending beyond 12 months. Furthermore, the combination of metronomic cyclophosphamide and maximum tolerated dose liposomal doxorubicin was assessed in metastatic patients, resulting in a clinical benefit rate of 75% and a median overall survival of 6.4 months. More recently, a study in pre-treated metastatic breast cancer patients examined the combination of metronomic cyclophosphamide and methotrexate. The median progression-free survival and overall survival were found to be 5 and 7 months, respectively, with 1 patient out of the 48 enrolled achieving a complete response. In a Phase 2 study, researchers conducted an assessment of the safety and efficacy of metronomic oral chemotherapy in patients with hormone receptor-positive metastatic breast cancer. A total of 43 patients in the treatment-naive group, and 65 in the pre-treated group, participated in the study. The treatment regimen consisted of vinorelbine, 40 mg thrice weekly, cyclophosphamide, 50 mg daily, and capecitabine, 500 mg thrice daily. In the treatment-naive group, the median TTP reached 25.1 months, whereas in the pre-treated group, it was notably shorter at 11.2 months. Among the reported treatment-related adverse events, grade 2 leukopenia and hand and foot syndrome were the most frequently observed. In summary, the metronomic combination of cyclophosphamide, capecitabine, and vinorelbine demonstrated significant activity and exhibited good tolerability, particularly among patients with hormone receptor-positive metastatic breast cancer. Shifting our focus to triple-negative breast cancer, it's crucial to acknowledge the limited availability of data concerning the benefits of metronomic cyclophosphamide, capecitabine, and vinorelbine as the initial treatment for patients dealing with metastatic triple-negative breast cancer. In a Phase 2 study, investigators thoroughly explored the safety and effectiveness of metronomic oral chemotherapy. This involved the administration of vinorelbine, 40 mg orally thrice weekly, cyclophosphamide, 50 mg daily, and capecitabine, 500 mg thrice daily, collectively known as the VEX regimen. The study exclusively enrolled previously untreated patients with metastatic triple-negative breast cancer. A total of 25 patients participated in this study, leading to notable results. The objective response rate was 27%, and the clinical benefit rate was 50%. The overall survival demonstrated a noteworthy median of 18.4 months. Commonly observed grade 1 to 2 adverse effects included nausea, diarrhea, leuko/neutropenia, and reversible liver enzyme alterations. Notably, grade 3 events, such as hand and foot syndrome, occurred in only 9% of cases. In summary, the VEX regimen showcased substantial activity and commendable tolerability, as the primary therapeutic approach for a specific subset of metastatic breast cancer patients, afflicted with triple-negative disease. Metronomic chemotherapy was also explored in the context of targeted therapy. In this scenario, the researchers considered the potential benefits of incorporating a vascular endothelial growth factor, VEGF, inhibitor, such as bevacizumab, to enhance metronomic chemotherapy for previously treated metastatic breast cancer patients. Patients who had become refractory to anthracycline and taxane treatments were administered cyclophosphamide at a daily dose of 50 mg orally, methotrexate at 1 mg/kg intravenously every 14 days, and bevacizumab at 10 mg/kg intravenously every 14 days. In cases of HER2 overexpressing tumors, trastuzumab was added to the treatment regimen. Following a median follow-up period of 7.7 months, the study yielded promising results. The response rates indicated partial response in 31.8% of patients, while 31.8% experienced stable disease. Overall, clinical benefit was observed in 63.6% of cases. Median progression-free survival reached 7.5 months, with an overall survival of 13.6 months. Importantly, adverse effects were mild, further supporting the viability of the combination of bevacizumab and metronomic-based chemotherapy. This approach proved effective, well tolerated, and provided clinical benefit, particularly among heavily treated metastatic breast cancer patients. Let's now explore metronomic regimens that involve slightly higher doses in breast cancer treatment. In the first study, doctors employed a metronomic-based chemohormonal approach, combining cyclophosphamide with migestrol. This regimen was administered to 29 patients, resulting in an objective response rate, ORR, of approximately 31.0%. In another study, an all-oral regimen was utilized. This regimen included cyclophosphamide, at a daily dose of 65 mg/m2 on days 1 to 14, along with capecitabine, at 1000 mg/m2 twice daily on days 1 to 14, with treatment cycles repeating every 28 days. A total of 68 previously treated patients were assessed, and after a median follow-up of 26 months, a clinical benefit, CB, was observed in approximately 53% of these patients. It's important to note that only 5% of patients experienced grade 4 toxicity, indicating manageable side effects. In a similar vein, a third study employed a regimen comprising cyclophosphamide, at 33 mg/m2 twice daily on days 1 to 14, alongside capecitabine, at 828 mg/m2 twice daily, with treatment cycles repeating every 3 weeks. This approach yielded a clinical benefit rate of approximately 57.8%, and notably, there were no grade 4 toxicities reported. In all 3 studies, these metronomic regimens demonstrated reasonable responses and clinical benefits, with minimal toxicity. These findings hold promise for breast cancer patients, and highlight the potential of such treatments in the field of oncology. Let's turn our attention to another intriguing study in the field of metastatic breast cancer. This study focuses on the use of metronomic chemotherapy, combined with aromatase inhibitors, or AIs, in treating hormone receptor-positive advanced breast cancer. Endocrine therapy is a key treatment for this type of cancer. Yet, the effectiveness of combining this therapy with chemotherapy remains a subject of ongoing research. The study in question aimed to shed light on this, by examining the clinical efficacy of combining AIs with metronomic capecitabine. The researchers conducted a retrospective analysis of 407 patients, all diagnosed with hormone receptor-positive advanced breast cancer. They divided these patients into 2 distinct groups. The first group, comprising 305 patients, received only AIs. In contrast, the second group, with 102 patients, was treated with both AIs and capecitabine as their first-line treatment. Capecitabine was administered at 500 mg 3 times daily in a metronomic fashion. The primary focus here was on progression-free survival, an essential indicator in cancer treatment effectiveness. Moving on to the results, the study found some compelling data. Over a median follow-up period of 47 months, with a range from 3 to 119 months, the outcomes between the 2 groups showed notable differences. The median progression-free survival in the group receiving combination therapy was significantly longer, 22 months, compared to just 14 months in the group receiving only AIs. Furthermore, the overall survival was also markedly better in the combination group, at 66 months versus 49 months in the AI-only group. To conclude, the study presents strong evidence that the combination of AIs and metronomic capecitabine significantly improves both progression-free survival and overall survival in patients with hormone receptor-positive advanced breast cancer. These findings suggest that integrating metronomic chemotherapy with endocrine therapy could be a more effective approach than endocrine therapy alone, offering a potential new direction in treating this challenging disease. Now, let's explore the results of a significant study in breast cancer treatment, specifically focusing on metronomic chemotherapy, as a presurgical, or neoadjuvant therapy. This study, a phase 2 trial, was conducted by Dr. Giuseppe Cancello and colleagues from the European Institute of Oncology. Triple-negative breast cancers exhibit aggressive behavior and lack targeted therapies. This reality drives the search for new treatments. Dr. Cancello's study examined the effectiveness and safety of a neoadjuvant regimen, based on metronomic principles. This regimen, known as ECF, combines epidoxorubicin, cisplatin, and low-dose 5-fluorouracil, followed by paclitaxel and metronomic oral cyclophosphamide. The study group comprised patients with HER2-negative breast cancer, specifically those with low levels of estrogen and progesterone receptors. In this trial, 34 patients participated. Remarkably, 91% of them, equating to 31 patients, responded positively to the treatment. Of these, 56%, or 19 patients, achieved a complete pathologic response, PCR. Stable disease was observed in 3 patients, and none showed disease progression. The study also carefully monitored adverse effects. In terms of serious hematologic side effects, these were relatively low: leukopenia in 9% of patients, and anemia in 3%. Only one patient experienced a significant non-hematologic toxicity, namely stomatitis. Compared to the current Keynote 522 trial, which showed that adding pembrolizumab improved PCR rates from 51.2% to 64.8%, this comparison is intriguing. It suggests that the Metronomic approach can achieve PCR rates comparable to those of modern immunotherapy. This leads to an interesting proposition: future trials might investigate the combination of Metronomic chemotherapy with pembrolizumab for potentially better outcomes. In summary, the study concludes that the ECF regimen, followed by weekly paclitaxel and Metronomic cyclophosphamide, is highly effective. It results in high PCR rates, and is associated with a low toxicity profile. These findings offer a promising direction for treating challenging cases of breast cancer. Let's now examine a similar study conducted by Dr. Masuda in Japan, which yielded comparable results to the previous trial we discussed. Dr. Masuda's research also focused on preoperative chemotherapy in patients with triple-negative breast cancer. The study explored a regimen of Metronomic paclitaxel, cyclophosphamide, and capecitabine, abbreviated as MPCX, followed by 5-fluorouracil, epirubicin, and cyclophosphamide (FEC). In this study, 40 primary TNBC patients received 4 cycles of Metronomic paclitaxel, administered at 80 mg per meter 2, weekly, cyclophosphamide, 50 mg daily, and capecitabine, 1,200 mg per meter 2, daily. This regimen was then followed by 4 cycles of 5-FU, 500 mg per meter 2, epirubicin, 100 mg per meter 2, and cyclophosphamide, 500 mg per meter 2, every 3 weeks. M2 means the body surface area, BSA, in square meters. The results of Dr. Masuda's study were notable. The complete pathologic response, PCR, rate was 54.5%. Additionally, the overall clinical response rate was high at 90.0%. Regarding safety, the study reported grade 3 to 4 adverse events, which included neutropenia in 35% of the patients and hand-foot syndrome in 8%. In conclusion, Dr. Masuda's study found that the Metronomic PCX regimen followed by FEC chemotherapy was associated with a high PCR rate and relatively low toxicity in TNBC patients. These findings further reinforce the potential of Metronomic chemotherapy regimens in the treatment of this challenging cancer type. Ixabepilone is a microtubule stabilizer, approved for use on its own, or in combination with capecitabine. It's intended for patients with metastatic breast cancer, who have demonstrated resistance to anthracyclines and taxanes. This drug is a semisynthetic analog of ipothalone B, with microtubule inhibitory activity. What makes ixabepilone especially intriguing is its ability to bypass common resistance mechanisms, which is why it may be a preferred choice for patients with recurrent disease. Dr. Fountsilas, from Aristotle University in Greece, conducted a randomized non-comparative phase 2 study to explore the activity and safety of 2 different ixabepilone schedules as first-line chemotherapy for metastatic breast cancer. In this study, 64 patients were divided into 2 groups. Group A received ixabepilone at a dose of 40 mg per square meter every 3 weeks, while Group B received ixabepilone at a dose of 20 mg per square meter on days 1, 8, and 15 every 4 weeks. The primary endpoint of the study was the overall response rate. Group A achieved a 47% response rate, while Group B had an even better response rate of 50%. After a median follow-up of 22.7 months, the median progression-free survival was 9 months in Group A, and 12 months in Group B. Median survival was 26 months in Group A, and it was not reached in Group B. It appears weekly treatments are superior to every 3 weeks treatment, although this is a non-comparative study. Now, let's talk about safety. The most common severe adverse events observed were neutropenia, 32% in Group A, and 23% in Group B, metabolic disturbances, 29% in Group A, and 27% in Group B, and sensory neuropathy, 12% in Group A and 27% in Group B. In conclusion, ixabepilone demonstrated a manageable safety profile in both the 3-weekly and weekly schedules, with fewer side effects observed in the weekly treatment. This opens up exciting possibilities for improving treatment outcomes for patients with metastatic breast cancer. Metronomic chemotherapy has also been examined in the adjuvant setting, which is to say, as a preventative treatment in triple-negative breast cancer, TNBC. A noteworthy study in this domain was a Phase 3 trial, led by Dr. Khalid Nasser from Egypt. Patients in this trial received adjuvant chemotherapy, comprising FEC 100, a regimen consisting of 5-fluorouracil, at 500 mg per square meter of body surface area, epirubicin at 100 mg per square meter of BSA, and cyclophosphamide at 500 mg per square meter of BSA on the first day. This regimen was administered for 3 cycles, followed by docetaxel at 80 mg per square meter of BSA, and carboplatin with an area under the curve, AUC, of 5 for an additional 3 cycles. For those for whom it was deemed necessary, postoperative radiotherapy was administered. This was succeeded by maintenance metronomic chemotherapy. For the maintenance phase, patients were given oral cyclophosphamide at 50 mg per day, along with methotrexate at 2.5 mg, taken twice daily on the first and second days of each week. These cycles were repeated every 28 days, and continued until either toxicity, disease recurrence, or the completion of 1 year. A total of 158 patients were involved in the study, divided into 2 groups, with 78 in Group 1 and 80 in Group 2. The mean age among these patients was 46 years. When comparing the outcomes, the median disease-free survival, DFS, for Groups 1 and 2 was 28 and 24 months, respectively, while the median overall survival, OS, for the 2 groups was 37 and 29 months, respectively. During the follow-up, the overall rates of distant metastasis recurrence were 26% for Group 1 and 37% for Group 2. Notably, both groups tolerated the treatment protocol with only mild toxicity profiles. In conclusion, the extended adjuvant metronomic chemotherapy regimen led to a significant improvement in survival, and was well tolerated by patients. These findings underscore the potential benefits of metronomic chemotherapy as a maintenance therapy in TNBC. In a study conducted in Italy, Dr. Francesca De Iulis examined the use of low-dose oral vinorelbine on a metronome schedule in elderly breast cancer patients with metastatic breast cancer, MBC. The study involved 32 patients with a median age of 76 years. These patients were administered oral vinorelbine at a dose of 30 mg, with 1 day on and 1 day off, until either disease progression, or the occurrence of unacceptable levels of toxicity. The study revealed a clinical benefit of 50%. The metronomic oral administration of vinorelbine, with its intermittent on and off schedule, proved to be well tolerated and safe in this specific elderly patient population. Furthermore, this approach enhanced patient adherence to the treatment regimen. Notably, there were no reported instances of grade 3 or 4 adverse events. In conclusion, the study's findings suggest that metronomic vinorelbine may hold promise as a potential treatment option for elderly breast cancer patients. Its use could potentially reduce adverse effects, and improve the overall quality of life for these individuals. Victor-6 study is a multi-center Italian retrospective study. It collected data on metronomic chemotherapy in patients with metastatic breast carcinoma treated between 2011, and 2016. Metronomic chemotherapy regimen was vinorelbine-based, cyclophosphamide-based and capecitabine-based combinations. A total of 112 patients were part of this study. Upon commencing metronomic chemotherapy, the median age of the patients was 81 years, with 33% of them selecting metronomic chemotherapy as their first-line treatment choice. The study found an overall response rate of 27.9%, and a disease control rate of 79.3%. Median progression-free survival ranged from 7.6 to 9.1 months, while overall survival ranged between 14.1 and 18.5 months. The most significant observed toxicity was hematological, affecting 24.1% of patients. Severe toxicity rates varied, with skin toxicity at 0.9%, and hematological toxicity at 8%. In summary, this extensive study on metronomic chemotherapy, in elderly patients with metastatic breast carcinoma, offers valuable insights for further exploration in this specific subgroup of frail patients. Dr. Giannini, from the Department of Oncology at the University of Turin in Italy, conducted a retrospective analysis of 110 patients, who had previously undergone treatment for metastatic breast cancer. These patients were administered oral etoposide at a low dose of 50 mg per day for 20 days within 28-day cycles. The median number of prior chemotherapy lines was 5, with tumor response and median overall survival rates at 6.4% and 10.6 months, respectively. Interestingly, etoposide's effectiveness was not influenced by the number of previous treatments, or the type of metastatic involvement. Importantly, oral etoposide was well tolerated, with only 2 patients discontinuing therapy due to toxicity. In this extensive analysis conducted at a single institution, the use of oral etoposide proved to be a valuable and safe option for patients with pretreated metastatic breast cancer. It may be considered as a treatment choice for patients who have not responded to other approaches, but are still suitable for chemotherapy. Metastatic breast cancer is a complex and diverse disease. It offers specific treatment targets, allowing for a gradual, step-by-step approach to enhance survival. In this context, metronomic treatments have received extensive research attention. In the metastatic setting, for tumors expressing hormone receptors, several treatment options have demonstrated their efficacy. These include weekly paclitaxel, oral vinorelbine, capecitabine, and ixabepilone, each with its distinct set of side effects to be considered. Now, when addressing triple-negative tumors, the standard approach has become the use of capecitabine. It is often administered after the neoadjuvant setting for patients who still have residual disease. This strategy holds promise in improving treatment outcomes. For heavily pretreated patients seeking palliative care, oral cyclophosphamide and etoposide have been employed. These drugs may be used either individually or alternated to offer relief and enhance the quality of life. The EORTC 75111 study, conducted across 30 institutions in 8 European countries, was an open-label, investigator-initiated Phase 2 trial. In this Phase 2 study, elderly patients, aged 70 and above, with HER2-positive metastatic breast cancer, were randomized to receive first-line chemotherapy with metronomic oral cyclophosphamide, along with HER2-directed trastuzumab and pertuzumab. Patients were given trastuzumab intravenously, with a loading dose of 8 mg/kg, followed by 6 mg/kg every 3 weeks, and pertuzumab intravenously, with a loading dose of 840 mg, followed by 420 mg every 3 weeks. An alternative group received the same treatment but added metronomic oral cyclophosphamide at a daily dose of 50 mg. This treatment continued until disease progression or the occurrence of unacceptable toxicity. In the event of disease progression, patients had the option to receive intravenous trastuzumab emtansine, as part of the protocol treatment, administered at 3.6 mg/kg every 3 weeks. Trastuzumab emtansine is also known by its brand name Kadcyla and TDM1. A total of 39 patients were randomly assigned to the pertuzumab-trastuzumab arm, while 41 patients were designated to the pertuzumab-trastuzumab cyclophosphamide arm. The median follow-up period extended to 54.0 months. When assessing treatment response, it's noteworthy that the pertuzumab-trastuzumab group achieved a 44% overall response rate, whereas the pertuzumab-trastuzumab cyclophosphamide group demonstrated a higher rate of 53%. These assessments were conducted among 72 patients with measurable disease at the study's outset. In the updated primary analysis, the estimated progression-free survival at 6 months was 43.1% in the pertuzumab-trastuzumab group, and notably increased to 73.0% in the pertuzumab-trastuzumab cyclophosphamide group. This remarkable difference of 29.9% resulted from the inclusion of Metronomic oral cyclophosphamide. At the 24-month milestone, progression-free survival figures were 18.7% and 28.7% respectively. The substantial improvement in progression-free survival at 6 months persisted at 12 and 24 months, highlighting the effectiveness of Metronomic cyclophosphamide. The extended follow-up of the EORTC 75111 trial reconfirms the effectiveness and safety of a taxane-free regimen in this context. Notably, combining Metronomic low-dose chemotherapy with trastuzumab and pertuzumab proved more effective compared to dual anti-HER2 therapy alone. Regarding overall survival, no significant difference was observed between the two arms, 32 versus 37 months. However, it's essential to recognize that this trial wasn't explicitly designed for overall survival analysis. Both treatment regimens were generally well tolerated, with no discernible increase in high-grade toxicity upon the addition of Metronomic low-dose cyclophosphamide. In conclusion, a Metronomic low-dose chemotherapy-based dual blockade approach, followed by TDM1 in cases of disease progression, emerges as an active and relatively well-tolerated treatment choice for an older and frail HER2-positive patient population, resulting in a median survival exceeding 3 years. Now, let's turn our attention to prostate cancer. A significant breakthrough came with the introduction of docetaxel, a semi-synthetic taxane, in the treatment landscape. Its superiority over mitoxantrone was established through the pivotal phase 3 study, known as TAX 327, leading to its adoption as the standard of care in 2004. In this study, a total of 1,006 patients diagnosed with metastatic, castration-resistant prostate cancer were enrolled. They were randomly assigned to one of 3 treatment groups: mitoxantrone at a dose of 12 mg per square meter every 3 weeks, docetaxel at 75 mg per square meter every 3 weeks, or docetaxel at 30 mg per square meter weekly for 5 out of every 6 weeks. All patients across these groups also received prednisone at a dose of 5 mg twice daily. The results were compelling. The group receiving docetaxel every 3 weeks exhibited significantly longer survival, with a median survival of 19.2 months compared to the mitoxantrone group, which had a median survival of 16.3 months. Furthermore, it's worth noting that weekly docetaxel demonstrated substantial improvements in the quality of life for patients, when compared to mitoxantrone. However, it's important to mention that there was no statistically significant difference in survival between the weekly docetaxel regimen and mitoxantrone. As a result of the TAX 327 study, docetaxel at a dose of 75 mg per square meter became the established first-line chemotherapy for patients with metastatic castration-resistant prostate cancer. This landmark study has significantly impacted the treatment landscape for this condition. As I previously mentioned, docetaxel, when administered every 3 weeks, constitutes a standard treatment for castration-resistant advanced prostate cancer. But intriguingly, new research points to biweekly schedules as potentially more efficacious. This information comes from the work of the Prostate Study Group in Europe, which compared the standard 3-week regimen to a 2-week cycle of Taxotere. Their investigations revealed that the 2-week cycle holds an advantage over the traditional method. In their Phase 3 study, researchers divided patients into 2 groups. One received 75 mg per square meter of docetaxel intravenously at the start of a 3-week cycle, while the other received 50 mg per square meter on the 1st and 15th days of a 4-week cycle. Each patient also took 10 mg of oral prednisolone daily. The study included 177 patients on the biweekly regimen, and 184 on the 3-week cycle. The results were significant. The group on the biweekly schedule experienced a longer period before treatment failure, 5.6 months compared to 4.9 months in the 3-week cycle group. Moreover, the biweekly group saw marked improvements in overall survival and progression-free survival, critical indicators of the treatment's success in extending life and halting cancer progression. Additionally, the rate of severe adverse events, including febrile neutropenia, was higher in the 3-week cycle group, with a 14% incidence compared to only 4% in the biweekly group. Furthermore, the patient's quality of life, a paramount consideration, showed significant improvements. Those in the biweekly treatment arm reported better overall quality of life and less pain, according to patient-reported outcomes. This means the biweekly regimen not only extended lives but also enhanced the quality of those lives. To conclude, the findings indicate that a biweekly administration of docetaxel not only prolongs the time to treatment failure, but is also more favorably tolerated, presenting a promising alternative to the standard 3-week regimen. This could represent a paradigm shift in the treatment approach for those facing this formidable type of prostate cancer, particularly for patients who may not tolerate the standard dosing schedule. A Phase 2 study from South Korea explored a biweekly chemotherapy protocol, focusing on the use of docetaxel combined with androgen deprivation therapy, for treating metastatic castration-naive prostate cancer. The study's inclusion criteria was stringent, selecting patients with previously untreated metastatic prostate cancer. These individuals underwent treatment with androgen deprivation therapy, and docetaxel, administered at a dose of 40 mg per square meter. This treatment was given biweekly over a course of up to 12 cycles. The study registered a total of 42 patients, all of whom were closely monitored for outcomes. Over a median follow-up duration of 25 months, a notable 95% of the patients exhibited a PSA response, with the average lowest PSA level being 0.42 nanograms per milliliter. Additionally, the median cancer-free survival time was recorded as 26.4 months. The most frequent adverse event was anemia, reported in 95% of the patients. Other noted side effects included nail changes in 33% of patients, fatigue in 29%, and oral mucositis in 26%. Notably, severe adverse events, those classified as grade 3 or higher, were uncommon. In summary, the outcomes of this study indicate that the biweekly regimen of docetaxel, plus androgen deprivation therapy is a feasible treatment option. Crucially, its clinical efficacy seems comparable to the conventional tri-weekly regimen of docetaxel 75 mg per square meter, combined with androgen deprivation therapy. This finding suggests that the efficacy of treatment is not diminished by the biweekly schedule. We've seen data suggesting biweekly Taxotere might be more beneficial than traditional 3-week schedules. This naturally leads us to the efficacy of weekly metronomic chemotherapy in treating advanced prostate cancer. Indeed, over the last 30 years, various regimens of metronomic chemotherapy, using a weekly schedule, have been scrutinized in advanced prostate cancer patients. It is crucial to note that most of these studies occurred before the advent of new hormonal or cytotoxic agents, such as abiraterone, enzalutamide, apalutamide, darolutamide, and cabazitaxel. These novel treatments have significantly changed the therapeutic landscape. The benefits of metronomic chemotherapy have often been evaluated in smaller, non-randomized trials, or through retrospective analyses. Thus, it is not currently considered a standard treatment option for advanced prostate cancer. Yet, metronomic chemotherapy finds its niche as a therapeutic alternative for patients who have exhausted all available treatments, or those who are not suitable candidates for standard chemotherapy regimens. In fact, many studies have shown the efficacy of this approach in advanced prostate cancer patients. These studies not only demonstrated anti-tumor activity, reflected by a 30 to 50% decline in prostate-specific antigen levels, but also highlighted an exceptionally favorable safety profile. This is particularly relevant for elderly and frail patients, who constitute a significant portion of this patient population. For example, in a recent study by Dr. Kolvani, a combination of metronomic cyclophosphamide, dosed at 50 mg, with corticosteroids, either dexamethasone at 1 mg or prednisone at 10 mg, induced biochemical responses, specifically, at least a 50% reduction in PSA levels, in half of the participants. However, there is a caveat. Only one study has evaluated the activity of metronomic chemotherapy in patients previously treated with docetaxel and one or more novel endocrine agents. In this subset of patients, single-agent cyclophosphamide resulted in a relatively modest rate of PSA response, only 16%, with progression-free survival, and overall survival, averaging at 4 and 8.1 months, respectively. This suggests that the promising results observed prior to the era of new therapies may not be directly replicable in the current cohort of patients who have undergone standard treatments. In the realm of prostate cancer treatment, the classical approach of metronome chemotherapy, involving cyclophosphamide and low doses of corticosteroids, once showed promising results. This approach predates the widespread use of modern taxane-based chemotherapies. The question arises, does this older methodology still hold relevance in today's advanced treatment landscape for prostate cancer? To address this, two recent studies offer insight, one reinforcing its efficacy, while the other suggests a diminished response and survival rate. The first study of interest, conducted by Dr. Nicola Kolvani in Italy in 2019, centered on the effectiveness of this regimen in treating advanced or metastatic castration-resistant prostate cancer in the modern context of standard chemotherapies, like docetaxel and cabazitaxel, as well as newer hormonal treatments, such as abiraterone and enzalutamide. This retrospective analysis encompassed 37 patients. Each patient received an oral dose of 50 mg cyclophosphamide daily, complemented by a low dose of corticosteroids, either dexamethasone, 1 mg per day, or prednisone, 10 mg per day. The results were noteworthy. 51% of the patients experienced a PSA decline of 50% or more. The median progression-free survival and overall survival rates stood at 11 and 28 months, respectively. Impressively, for patients who achieved a PSA decline of 50% or greater, the median PFS and OS extended to 14 and 35 months, respectively. Furthermore, patients tolerated the treatment exceptionally well. Given these findings, the study posits that oral metronomic cyclophosphamide, paired with low doses of oral dexamethasone or prednisone, could be a viable and safe therapeutic option. This applies not only to CRPC patients who are unsuitable for standard treatments, but also to those who have undergone extensive prior treatment. Let's examine Dr. Cafo's retrospective analysis, which involved a cohort of 74 patients with CRPC. Each individual in this study was administered a daily oral dose of 50 mg of cyclophosphamide. The objective was clear: to assess the drug's activity in a group of patients who had already received, and not responded to, prior treatments. The results of Dr. Cafo's study are quite informative. Firstly, the treatment was generally well received, with patients showing good tolerability to the Metronomic cyclophosphamide regimen. This is a crucial factor, as it means the treatment is potentially manageable over the long term. A notable 16% of the patients in the study experienced what we call a major biochemical response. This is evidenced by significant changes in the levels of prostate-specific antigen. In terms of survival metrics, the study reported a median progression-free survival time of 4.0 months, and a median overall survival time of 8.1 months. While these figures may not seem extensive at first glance, they are significant for a patient population that has already undergone multiple lines of therapy. Concluding the study, Dr. Cafo suggests that metronomic cyclophosphamide could be a valuable and cost-effective treatment option within the modern therapeutic landscape of metastatic CRPC. Although the efficacy may not match the more promising results seen in Dr. Kalvani's study, it's important to recognize the potential of cyclophosphamide as part of a tailored treatment strategy for certain patients with prostate cancer. Turning our focus to another innovative approach, in the treatment of metastatic castration-resistant prostate cancer, CRPC, let's discuss a study that examines the clinical activity of oral metronomic vinorelbine, VNR, in combination with dexamethasone, DX. This protocol represents a different avenue of treatment, distinct from the cyclophosphamide-based regimen we previously discussed. The study in question aimed to investigate the effects of a regimen, combining 30 mg of oral vinorelbine, administered 3 times a week, with 1 mg of oral dexamethasone, taken daily until the disease progressed. This treatment was given to 41 patients, a notable 92% of whom were resistant to chemotherapy, underlining the challenging circumstances of the study group. In terms of outcomes, there was a noteworthy finding: 35% of the patients experienced a decrease in prostate-specific antigen, PSA, levels of 50% or more from the baseline. This level of response is significant, particularly in a population with prior chemotherapy resistance. When we consider the survival metrics, the median progression-free survival, PFS, was recorded at 4 months, and the median overall survival, OS, extended to 17.5 months. These figures are particularly encouraging, especially given the context of the patient population's prior treatment resistance. An important aspect of any cancer treatment is the balance between efficacy and tolerability. In this study, the toxicity associated with the vinorelbine and dexamethasone protocol was mild. Remarkably, no grade 4 toxicities were reported, which speaks to the treatment's safety profile. In summation, the combination of metronomic vinorelbine and dexamethasone has demonstrated favorable activity and a low toxicity profile in patients with metastatic CRPC. These findings bolster the potential of metronomic therapies in managing advanced prostate cancer, providing a hopeful outlook for those who may not have responded to traditional chemotherapy. Now, let's examine a recent study that utilized the CASE protocol, a combination of 4 drugs, administered in a metronome fashion. The CASE regimen was structured into a 2-week cycle. During the initial week, patients received cyclophosphamide at 50 mg twice a day, along with ketoconazole at 200 mg, which was taken 3 times daily. In the second week, the treatment consisted of estromustine at 140 mg and etoposide at 50 mg, both administered twice daily. Additionally, prednisolone at a dose of 10 mg was provided once daily throughout the entire cycle. Significantly, all medications in this protocol were administered orally. The commencement of the treatment schedule was flexible, based on the physician's judgment. Options included a continuous regimen, a 6-week schedule with a subsequent 2-week intermission, or alternatively, a 2-week schedule followed by a 1-week rest period to facilitate patient recovery. Turning our focus to the outcomes of the case protocol, we find promising results within a cohort of heavily pretreated patients in the current treatment era. The protocol has been particularly noteworthy in its application to patients who have previously undergone extensive treatment, including at least one taxane and androgen receptor-targeted agents, like abiraterone and enzalutamide. In the principal study group, the median overall survival was recorded at 12.3 months, with a median progression-free survival of 4.4 months. A biochemical response, indicated by a reduction in prostate-specific antigen, PSA, was observed in 29% of patients, while a decrease in any PSA levels was noted in 65% of the study population. Interestingly, progression-free survival appeared to remain consistent across various lines of treatment, whether patients had been previously treated with 1 or 2 taxanes, androgen receptor-targeted agents, or radium-223. This consistency in progression-free survival was mirrored by the biochemical response, which was evident across all patient subgroups evaluated in the study. Now, let's discuss the tolerability aspects of the case regimen, and navigate through the data together. In this study, of the 123 participants, 38 patients, which represents 31%, had to discontinue the treatment. The discontinuation was due to adverse events, or a worsening performance status, as measured by the Eastern Cooperative Oncology Group, or ECOG. The main adverse events leading to treatment discontinuation were bone marrow toxicity, fatigue, infection, and elevated liver function tests. Moving on to thromboembolic events, 20 patients, or 16% of the study group, experienced such events. Furthermore, 43 patients, representing 35% of the group, required hospitalization for various reasons. Infections were another concern, with 26 patients, accounting for 21% of the group, needing antibiotics or antivirals, including treatments for urinary tract infections. Notably, there were only 2 cases of febrile neutropenia. Lastly, the study reported 4 deaths during the treatment period. One of these deaths, upon review, was attributed to disease progression, and 3 were related to infections. It is worth mentioning that only one of these infection-related deaths occurred in a patient with grade 3 neutropenia. Understanding these statistics helps us grasp the risks associated with treatments, and underscores the importance of close monitoring for those undergoing such therapies. In conclusion, the case regimen emerges as a reasonable treatment strategy for those who have undergone significant previous treatment for metastatic castration-resistant prostate cancer, presenting manageable toxicity, and a higher biochemical response rate, compared to other similar late-line therapies. It's essential for clinicians to consider these factors when devising treatment plans for such patients. In the upcoming presentations, I will be discussing ovarian cancers. Metastatic epithelial ovarian cancer continues to be a persistent and serious health concern, highlighting the urgent need for additional treatment options. For patients who have already received substantial prior treatments, oral metronomic cyclophosphamide is an important treatment component. In the context of platinum-resistant ovarian cancer, topotecan has established itself as an effective standalone treatment option. Moreover, bevacizumab has been authorized for use in both platinum-sensitive relapsed and resistant forms of ovarian cancer, playing a key role during both the induction and maintenance phases of therapy. At the same time, there is an increasing interest in expanding research and clinical trials, geared towards metronomic and angiogenesis-targeted treatment methods for these tumors. Notably, despite the inclusion of various metronomic regimens in the National Comprehensive Cancer Network's current guidelines for recurrent ovarian cancer, their adoption in routine clinical practice remains limited. This study was led by Dr. Emma Barber, alongside her colleagues at Northwestern University Feinberg School of Medicine, and the Robert Lurie Comprehensive Cancer Center. The main goal of their research was to assess the effectiveness, progression-free survival, and overall survival rates associated with a specific combination of treatments for ovarian carcinoma. These treatments include intravenous bevacizumab and oral cyclophosphamide. Bevacizumab was administered at a dosage of 10 mg per kilogram, every 14 days, while cyclophosphamide was given orally at 50 mg daily. This investigation was conducted retrospectively, focusing on patients who had previously undergone extensive treatment for recurrent ovarian carcinoma. A critical aspect of this study was that all patients showed resistance to platinum-based chemotherapy, either primarily or secondarily, at the time they received the treatment combination of bevacizumab and cyclophosphamide. The patients had a varied history of chemotherapy, with a median of 6.5 prior treatments, ranging from 3 to 16. However, treatment is not without its challenges. In this study, 8 patients, which is 12.1% of the group, experienced side effects, significant enough to require discontinuation of the treatment. There was also a report of a serious side effect, with one patient experiencing bowel perforation, representing 1.5% of the study group. Despite these challenges, the results of the treatment were notable. The overall response rate was 42.4%. This included a complete response in 7 patients, or 10.6%, and a partial response in 21 patients, which is 31.8%. Additionally, 15 patients, or 22.7%, achieved stable disease, while 23 patients, 34.8% of the group, experienced disease progression. When we look at the survival outcomes, the median progression-free survival for those who responded to the treatment was 5 months, with a range of 2 to 14 months. The median overall survival, OS, from the initiation of bevacizumab and cyclophosphamide treatment, was 20 months for responders, ranging from 2 to 56 months. For non-responders, the median OS was 9 months, with a range of 2 to 51 months. This difference in survival rates was statistically significant. In conclusion, the combination of bevacizumab and cyclophosphamide presents as an effective and generally well-tolerated chemotherapy regimen for heavily pretreated patients with recurrent ovarian carcinoma. This regimen not only improved progression-free and overall survival rates in responders, but also showed response rates that were comparable and favorable to those observed with other second-line chemotherapeutic agents used in similar patient populations. We're discussing a Phase 2 trial spearheaded by Dr. Rose of the Gynecologic Oncology Group at Case Western Reserve University. The focus of this study was to evaluate the effectiveness of prolonged oral etoposide in the treatment of ovarian carcinoma. The trial was particularly concerned with patients who had shown either resistance or sensitivity to platinum-based chemotherapy treatments. The central drug in this study, etoposide, was administered following a specific dosage regimen. Initially, patients were given 50 mg per square meter per day for a 21-day period, with this cycle repeating every 28 days. This dosage plan was designed for patients who had not received prior radiotherapy. In contrast, patients with a history of radiotherapy received a reduced starting dose of 30 mg per square meter per day, also over a 21-day cycle. A key component of this treatment approach was the ability to adjust the dosage based on each patient's individual response and tolerance. The etoposide dosage could be escalated to a maximum of 60 mg per square meter per day, allowing for a personalized treatment approach that aims to optimize efficacy while minimizing potential side effects. Let's delve into the results of the GOG study, led by Dr. Rose, focusing on ovarian carcinoma treatment. The study included 99 patients, with 97 assessable for toxicity, and 82 for response. Primary goal is to assess the treatment's effectiveness in patients with either platinum-resistant or platinum-sensitive ovarian carcinoma. Starting with the platinum-resistant group, among 41 patients, the response rate to the treatment was 26.8%. This was broken down into a 7.3% complete response and a 19.5% partial response. The median duration of response in this group was 4.3 months, and the median progression-free interval stood at 5.7 months. The median survival time was observed to be 10.8 months. Of note in this platinum-resistant group, 25 patients had previously been treated with paclitaxel. In this subgroup, 32% responded to the treatment. Turning our attention to the platinum-sensitive group, out of 41 patients, there was a 34.1% response rate. This included 14.6% who had a complete response, and 19.5% with a partial response. The median duration of response here was 7.5 months, with the median progression-free interval extending beyond 6.3 months. The median survival time for this group was significantly longer, at over 16.5 months. An important aspect of this study is the toxicity profile. The study reported that grade 3 or 4 hematologic toxicity was quite common. Specifically, leukopenia occurred in 41.2% of patients, thrombocytopenia in 9%, and anemia in 13.4%. There were also 3 treatment-related deaths, 2 resulting from neutropenic sepsis, and 1 from thrombocytopenic bleeding, due to an overdose. Additionally, there was 1 case of leukemia development, a serious concern. In summary, this treatment regimen was found to be active in managing both platinum-resistant and platinum-sensitive ovarian carcinoma, including cases resistant to paclitaxel. However, the risk of significant hematologic toxicity cannot be overlooked. This study provides valuable insights into the balance between the effectiveness and risks of this treatment approach in ovarian carcinoma, guiding future therapeutic strategies. Now, we're going to examine the results of a phase 2 trial, conducted by Dr. Maury Markman from the University of Texas, MD Anderson Cancer Center. This trial was part of the Gynecologic Oncology Group's efforts to understand the effectiveness of single-agent, weekly paclitaxel in treating ovarian cancer, specifically in patients who have shown resistance to both platinum-based treatments and paclitaxel when administered every 3 weeks. In this trial, 48 patients, all of whom had ovarian cancer resistant to both platinum and paclitaxel, were treated with single-agent weekly paclitaxel. The dosage was set at 80 mg per square meter per week, and the treatment continued until the disease showed progression. Now, let's focus on the outcomes. In this group of patients, who had already shown resistance to 2 major forms of chemotherapy, the objective response rate was 20.9%. This indicates that a noteworthy proportion of patients responded positively to this treatment approach. When it comes to safety and tolerability, which are crucial factors in any cancer treatment, serious adverse events were relatively uncommon in this trial. Specifically, neuropathy occurred at grade 2 in 21% of patients, and at grade 3 in 4% of patients. Additionally, grade 3 fatigue was reported in 8% of patients. In conclusion, the results from this study suggest that the weekly administration of paclitaxel can be an effective management strategy for women with ovarian cancer resistant to both platinum and paclitaxel, administered every 3 weeks. This finding provides valuable insight for oncologists seeking alternative treatment options for patients who have not responded to conventional chemotherapy regimens. A randomized phase 2 trial was conducted to explore the efficacy and safety of weekly administration of topotecan, compared to the conventional 5-day therapy in women facing platinum-resistant recurrent ovarian cancer. This trial aims to provide a clearer understanding of the benefits and potential drawbacks associated with each treatment approach. A total of 194 patients, from 54 different medical centers, were randomly assigned to 2 protocols. They were either administered topotecan at a dose of 4 mg per square meter weekly, or 1.25 mg per square meter daily on days 1 to 5. The results showed that clinical benefit was observed in 47% of patients receiving topotecan weekly, and 58% of those on the topotecan 5-day protocol. It was noted that patients in the topotecan weekly group had a slightly shorter progression-free survival but similar overall survival, when compared to those on conventional 5-day therapy. Moreover, the weekly administration of topotecan demonstrated significantly lower risks of anemia, neutropenia, and thrombocytopenia. In conclusion, when evaluating effectiveness, the conventional 5-day therapy remains the standard of care for patients with platinum-resistant recurrent ovarian cancer. However, the comparable overall survival and the favorable toxicity profile associated with the weekly administration of topotecan make it a viable alternative treatment option in this clinical context. In the context of advanced epithelial ovarian cancer, an evaluation of oral metronomic therapy was conducted retrospectively to assess patient outcomes. A total of 36 patients with advanced epithelial ovarian cancer were administered oral metronomic therapy. These patients had previously undergone a median of 2 rounds of chemotherapy. The oral metronomic therapy regimen consisted of a combination of cyclophosphamide, etoposide, and celecoxib, with or without pazopanib, in addition to receiving supportive care. The results revealed an overall response rate of 50%. The median progression-free survival was 8.2 months, while the median overall survival was 38 months. Notably, patients who had received 2 rounds of chemotherapy before commencing oral metronomic therapy, as well as those who were on pazopanib-based oral metronomic therapy, exhibited improved progression-free survival. For individuals facing relapsed and refractory epithelial ovarian cancer, oral metronomic therapy represents a viable treatment option. In a recent study from Poland led by Dr. Wysocki, a retrospective analysis was conducted on 72 advanced ovarian cancer patients undergoing metronomic low-dose chemotherapy. This treatment comprised either topotecan as a standalone agent, or its combination with cyclophosphamide, referred to as the CYTA regimen. The combination doses are topotecan 1 mg every other day, and cyclophosphamide 50 mg daily. The study revealed notable clinical benefits, with the median progression-free survival for all patients being 3.6 months, which increased to 10.7 months in those showing a biochemical response. Additionally, 27.2% of patients achieved positive response rates, while 86% attained disease control. Despite myelotoxicity being the most common treatment-related adverse event, affecting about a third of the patients significantly, this research was pivotal in being the first to report the safe and effective use of the topotecan and a cyclophosphamide combination in ovarian cancer. Overall, Wysocki's study highlighted the effectiveness of the combination regimen of topotecan and cyclophosphamide in metronomic low-dose fashion, providing significant clinical benefits in advanced ovarian cancer patients, even amidst a considerable incidence of treatment-related adverse events. Currently, a significant number of clinical trials and research studies are being conducted to assess the effectiveness of metronomic low-dose chemotherapy in the treatment of lung cancer. The preliminary results from these studies are quite encouraging, indicating that metronomic low-dose chemotherapy might play a crucial role in controlling the progression of lung cancer, particularly in its advanced or metastatic stages. In addition to being used as a standalone therapy, metronomic chemotherapy is also being investigated in combination with other treatment modalities, such as targeted therapy, immunotherapy, and radiation. This combined approach aims to enhance the overall efficacy of the treatment, by simultaneously targeting various mechanisms involved in cancer development and spread. When it comes to selecting patients for metronomic chemotherapy, it's important to note that it may not be suitable for all individuals with lung cancer. The appropriateness of this therapy is determined, based on a variety of factors, including the specific type and stage of lung cancer, the patient's history of previous treatments, their overall health status, and their personal treatment preferences. Now, we turn our attention to an extensive, multi-center phase 2 study, expertly led by Dr. Camerini. This research, conducted across several centers in Europe, was designed as a prospective, randomized, open-label trial. Its primary focus was on patients who had not yet received any treatment for their condition, known as treatment-naive patients. These individuals were diagnosed with TNM stage 3B, or stage 4 non-small cell lung cancer. Let's begin with Arm A, termed as the Metronomic low-dose regimen. Within this regimen, participants received oral vanoral at a consistent dose of 50 mg. This specific dosage was given 3 times each week. Moving on to Arm B, which represents the standard weekly schedule regimen. In this approach, patients were administered oral vanoral at a dosage ranging between 60 to 80 mg per square meter. This treatment was given once a week. A key finding was the median progression-free survival without grade 4 toxicity. For those receiving metronomic oral vanoral it was 4.0 months, compared to 2.2 months in the standard treatment arm. This indicates a significant delay in disease progression with the metronomic regimen. The disease control rate without grade 4 toxicity was also notable. In the metronomic oral vanoral group, this rate was 45.8%, as opposed to 26.8% in the standard treatment group, suggesting a higher level of disease control with metronomic treatment. Progression-free survival was another important measure, with the metronomic group achieving 4.3 months, and the standard group 3.9 months. In terms of overall survival, both groups had a similar median of around 7 months. Additionally, the quality of life was comparable across both treatment arms. Regarding treatment-related severe adverse events, they were less frequent in the metronomic oral vanoral arm, with only 25.3% of patients experiencing these effects, compared to 54.4% in the standard arm. Specifically, severe neutropenia occurred in 10.8% of the metronomic group, versus 42% in the standard group, highlighting a significant reduction in serious side effects. In conclusion, metronomic oral vanoral significantly extended the median progression-free survival without severe toxicity, in patients with advanced non-small cell lung cancer, unfit for platinum-based combinations as a first-line treatment. With a notable reduction in toxicity, and comparable overall survival in both groups, metronomic oral vanoral emerges as a vital treatment option for this challenging patient population, offering an effective balance between efficacy and safety. Of note, the outcome of unfit lung cancer patients is still poor. Let's explore a phase 2 study that investigated the impact of metronomic low-dose chemotherapy, in combination with bevacizumab, on advanced non-squamous, non-small cell lung cancer. This innovative approach in cancer treatment is particularly relevant for patients with this challenging form of lung cancer. In this study, the treatment was structured into 4-week cycles. The regimen included paclitaxel, at a dose of 80 mg per square meter, administered on days 1, 8, and 15. This was paired with gemcitabine, administered at a dose ranging from 200 to 300 mg per square meter on the same days. Additionally, bevacizumab was given at 10 mg per square meter on days 1 and 15. Patients underwent this treatment cycle for a total of 6 cycles. When examining the effectiveness of this treatment, the results were quite promising. Among the patients, 24 achieved an objective response, which included 1 complete response, and 23 partial responses. Additionally, 6 patients experienced stable disease, indicating a halt in the progression of their cancer. An interesting aspect of this study is that 40% of the patients had an EGFR mutation. Such mutations are known to potentially influence the effectiveness of certain treatments. Despite this, the combination of Metronomic low-dose chemotherapy with bevacizumab demonstrated a notable impact on the patient's disease, suggesting its potential effectiveness. Safety was a key focus as well, with both hematologic and non-hematologic toxicities being reported as very low. This is a significant consideration, as it suggests that the treatment extends the period of disease control while minimizing adverse effects, thus potentially improving the patient's quality of life. In conclusion, the findings from this Phase 2 study underscore the potential advantages of using a Metronomic low-dose chemotherapy regimen combined with bevacizumab in the treatment of advanced non-squamous non-small cell lung cancer. These results offer valuable insights and new possibilities for effective treatment strategies in this field of oncology, with a focus on both efficacy and safety. Let's discuss another common Metronomic low-dose chemotherapy approach in the treatment of non-small cell lung cancer, the use of oral etoposide. This particular chemotherapy has been widely studied and is administered in 2 different dosing strategies. One method involves a dose of 100 mg every other day, and the other is a Metronomic low dose of 50 mg daily. The effectiveness of oral etoposide in treating NSCLC has shown encouraging results. The rate of partial response to this treatment ranges between 20 to 30%. Furthermore, the median duration of survival for patients on this regimen is around 9 months. These outcomes represent significant findings in the ongoing search for effective treatments. Nab-paclitaxel, also known as Abraxane, demonstrates superior tumor tissue penetration compared to paclitaxel formulated with chromophore. This suggests that the optimal dosage of Abraxane may be lower than the widely adopted dose recommended by NCCN. In order to assess the clinical effectiveness and safety of Abraxane in patients with advanced non-small cell lung cancer, who had previously undergone treatment in Japan, a randomized Phase 2 trial was conducted. During the trial, patients were randomly assigned to 2 groups, one receiving Abraxane at a dosage of 100 mg per square meter, and the other at 70 mg per square meter on a weekly basis. A total of 81 patients participated in the randomization process. The results indicated similar outcomes for both groups in terms of progression-free survival, which averaged 3.7 months for the 100 mg group and 3.7 months for the 70 mg group, as well as overall survival with 13.5 months for the 100 mg group and 16.1 months for the 70 mg group. Additionally, the overall response rate was comparable, with 20.5% in the 100 mg group and 23.1% in the 70 mg group. However, it's essential to note that the incidence of grade 3 or more severe adverse events was higher in the 100 mg group, which is 57.5%, compared to the 70 mg group, which is 41.5%. Furthermore, the proportion of severe side effects was lower in the 70 mg group, with 4.9%, compared to the 10.0% observed in the 100 mg group. In conclusion, both the standard dose of 100 mg and the lower dose of 70 mg of Abraxane exhibit efficacy in previously treated non-small cell lung cancer patients, with the latter demonstrating a more favorable safety profile. Therefore, considering the results of this trial, the use of nab-paclitaxel at a dosage of 70 mg per square meter weekly appears to be a reasonable and viable option for the treatment of non-small cell lung cancer patients in similar clinical scenarios. Now, let's get into the topic of metronomic low-dose chemotherapy in gastrointestinal cancers. It's important to highlight that this approach has demonstrated significant potential, as evidenced by multiple Phase 2 single-arm studies and a few Phase 3 trials. Throughout this presentation, we will closely examine these trials and their associated data. We will thoroughly evaluate the compelling evidence that supports the incorporation of metronomic dosing into clinical practice. We firmly believe that our cancer treatments should not only be evidence-based, but also deliver effectiveness and genuine benefits to our patients. Effective treatment for older and frail individuals with gastroesophageal cancer has been found in a low dose of platinum-based chemotherapy. The Phase 3 GEO2 trial, conducted at the University of Edinburgh, involved over 500 participants with advanced gastroesophageal cancer. Remarkably, the trial revealed that the lowest tested dose, combining oxaliplatin and capecitabine, performed as effectively as the highest dose, in terms of delaying disease progression and minimizing side effects. The GEO2 trial's primary objective was to identify the ideal dosage of oxaliplatin and capecitabine for elderly or frail patients with advanced gastroesophageal cancer. This Phase 3 study included 514 individuals, aged 51 to 96, in the United Kingdom. Participants were randomly assigned to one of three chemotherapy dose levels. Level A, oxaliplatin at 130 mg per square meter of body area administered once every 21 days, along with 625 mg/m2 of capecitabine twice daily. Level B, oxaliplatin and capecitabine at 80% of the level doses. Level C, oxaliplatin and capecitabine at 60% of the level doses. After 9 weeks, participants were assessed using the overall treatment utility tool, which takes into account clinical benefits, tolerability, quality of life, and patient satisfaction. This groundbreaking study highlights the potential of low-dose chemotherapy as a viable and effective treatment option for older and frail individuals with gastroesophageal cancer. The duration of overall survival was consistent among all three dose levels, with a median of 7.5 months for the highest dose, 6.7 months for the medium dose, and 7.6 months for the low doses. Similarly, progression-free survival, indicating patients remained alive without disease worsening, was also comparable at 4.9 months, 4.1 months, and 4.3 months, respectively, for the high, medium, and low-dose groups. Notably, in the low-dose group, 43% achieved favorable clinical utility scores, in contrast to 35% and 36% in the high and medium dose groups, respectively. When it comes to overall survival, low-dose chemotherapy showed some improvement compared to best supportive care only, although this difference didn't reach statistical significance. On the other hand, both quality of life and fatigue were notably better for those undergoing chemotherapy than for those on best supportive care. In the world of cancer treatment, the saying, "less is more," is becoming more common, and it's proving to be beneficial for patients' quality of life. This particular trial aimed to strike a balance between improving the quality of life and extending survival for older and frail individuals receiving palliative treatment for gastroesophageal cancer. The data from this trial are vital, addressing a crucial need within this patient population. These findings hold importance because they offer a potential alternative for patients looking to slow down the progression of their disease. The GEO2 clinical trial reveals that, in the context of palliative chemotherapy for older and frail individuals, the objectives, including cancer control, may be better attained by using treatment doses that are significantly lower than what is currently considered standard. As expected, Individuals receiving the lowest chemotherapy doses encountered fewer adverse effects, compared to those receiving the medium or high doses. Severe side effects, categorized as grade 3 or higher, were observed in 56% of participants in the high or medium dose groups, in contrast to 37% of those in the low dose group. Next, I am going to discuss an interesting development in GI cancer treatment, focusing on a phase 2 study. This study aimed to improve a chemotherapy regimen known as FOXX, which was already noted for its good tolerability. The original FOXX regimen involved weekly administration of oxaliplatin, along with a 24-hour infusion of 5-fluorouracil and folinic acid. Researchers added another drug, irinotecan, to create the FOXX regimen. This approach was tested on patients with metastatic colorectal and gastric cancers who had not received prior treatment. In this FOXX regimen, the doses were administered weekly: irinotecan at 70 mg per square meter, oxaliplatin at 50 mg per square meter, folinic acid at 500 mg per square meter, and 5-fluorouracil at 2000 mg per square meter. This cycle was repeated, starting again from day 36. The study enrolled 22 patients in total, split evenly between those with metastatic colorectal and gastric cancers. Each patient underwent an average of 4 treatment cycles. The results were encouraging. In terms of effectiveness, the FOXX regimen showed a 46% overall response rate, with 55% response in colorectal cancer, and 36% in gastric cancer patients. The median progression-free survival ranged from 8 to 10 months, and the overall survival spanned from 15 to 18 months, varying slightly between the two types of cancer. The FOXX regimen was generally well tolerated, with no extreme toxicities or treatment-related deaths. The most common side effects, diarrhea and neutropenia, affected about a quarter of the patients. Due to these side effects, around half of the patients required dose reductions, especially those who had completed at least 2 treatment cycles. A key aspect of FOXX is its resemblance to a metronomic schedule. This means the regimen involves moderate or lower doses administered more frequently, in this case, weekly. This approach helped in significantly reducing life-threatening toxic events. Now, let's compare this with other triple therapies like FOXX or Zeloxiri. These regimens, while effective, have been associated with higher toxicity levels compared to FOXX. This lower toxicity profile of FOXX is particularly noteworthy because it maintains efficacy while reducing the risk of severe side effects. In conclusion, the FOXX regimen not only demonstrates excellent tolerance and efficacy but also represents a promising approach for future research. This is especially relevant for studies combining chemotherapy with biological targeted agents in gastrointestinal cancers. The success of FOXX, especially its metronomic-like schedule with moderate or lower doses, marks an important step in the evolution of chemotherapy regimens, providing a balance between effectiveness and patient quality of life. Now, I'd like to share an important study from my colleagues at Moffitt Cancer Center, as well as collaborators in Italy. This research focuses on the application of metronomic low-dose chemotherapy for colon cancer, specifically employing capecitabine and oxaliplatin, in conjunction with bevacizumab, to treat advanced colorectal cancer in elderly patients. In this study, 75 elderly individuals with advanced colorectal cancer were treated, the median age being 76. The treatment regimen was meticulously structured, commencing with a moderate dose of oxaliplatin, 65 mg per square meter, plus bevacizumab at 7.5 mg/kg, both administered on the initial day. Following this, capecitabine was given at a steady, moderate dose of 1000 mg twice daily from the 2nd to the 15th day, over a 3-week cycle, continuing for a maximum of 12 cycles. From the 76 patients included in the analysis, the research found a 50.1% tumor response rate, with a significant 86.7% of patients obtaining clinical benefits. The median progression-free survival reached 12.3 months, and the median overall survival was an impressive 23.5 months. These findings are quite remarkable, particularly when compared with high-dose chemotherapy trials. For context, data from the Surveillance, Epidemiology, and End Results (SER) program indicates that the survival of patients who received FOLFOX was on par with those who received FOLFIRI, with median overall survival times of 19.1 and 20.5 months, respectively. A notable outcome of this study was that no patients experienced grade 4 toxicity, suggesting a favorable safety profile for this regimen. An improvement in the quality of life scores was observed in all patients. In summary, the research illustrates that a fixed and moderate or low dose of capecitabine can mitigate the principal toxicity commonly associated with standard treatments for aged individuals with advanced colorectal cancer. Importantly, this lower toxicity does not seem to compromise the treatment's effectiveness. The substantial clinical benefits observed, along with improvements in patients' quality of life, provide strong support for the adoption of this Metronomic low-dose regimen. In the study titled, Intermittent versus Continuous Chemotherapy in Advanced Colorectal Cancer, a randomized trial, by the Italian Group for the Study of Gastrointestinal Cancer, ISCAD, researchers investigated the effects of chemotherapy in advanced colorectal cancer. Typically, this chemotherapy, commonly called FOLFIRI, is administered continuously until progression, which can lead to cumulative toxicity. The primary goal of this trial was to assess if intermittent chemotherapy would be as effective as the same regimen, given continuously. This assessment was made in patients with advanced colorectal cancer, who had not been previously treated with chemotherapy for metastatic disease. The study enrolled 337 patients from 27 institutions, who were divided into 2 groups. The first group received leucovorin, fluorouracil continuous infusion, and irinotecan every 2 weeks for 2 months, followed by 2 months off. The second group received the same regimen, but administered continuously. The main endpoint was overall survival, with secondary focuses on progression-free survival and toxicity. The results, noted over a median follow-up period of 41 months, showed that overall survival was comparable in both groups, with the intermittent therapy group having an overall survival of 18 months, and the continuous therapy group 17 months. Progression-free survival was also similar, at 6 months for both groups. The levels of severe toxicity, which primarily included bone marrow suppression, fever, and diarrhea, were similar across both groups. A notable observation was that, a similar percentage of patients in both groups received second-line treatment based on oxaliplatin. In the intermittent therapy group, the median period without chemotherapy, or drug holiday, was 3.5 months. In conclusion, the trial determined that reducing the intensity of therapy did not lessen the effectiveness of treatment for this patient group. This indicates that intermittent chemotherapy can be a viable option, offering comparable effectiveness, with potentially reduced cumulative toxicity. In the Phase 3 Nordic Act-2 trial, patients with KRAS-mutated colon cancer, who had not experienced disease progression for more than 18 weeks after their initial treatment, were enrolled in a randomization study. They were randomly assigned to receive either bevacizumab every 3 weeks, or capecitabine 500 mg twice daily using metronomic dosing. The results revealed a significant similarity between the 2 groups. The 3-month progression-free survival rates were 75% for the bevacizumab group, and 66.7% for the capecitabine group. Additionally, the median overall survival was 26.4 months for the bevacizumab group, and 28 months for the capecitabine group. These findings effectively confirmed that low-dose capecitabine used as maintenance therapy is non-inferior to bevacizumab. The CAIRO-3 study, a pivotal phase 3 trial, aimed to investigate the benefits of maintenance metronomic treatment with capecitabine and bevacizumab following initial induction therapy. This induction involved 6 cycles of CAPOX-B, comprising capecitabine, oxaliplatin, and bevacizumab. The study enrolled 558 treatment-naive metastatic colorectal cancer patients, evenly split into maintenance and observation groups, each with 279 participants. The maintenance regimen included oral capecitabine, at 625 mg per square meter twice daily and intravenous bevacizumab at 7.5 mg per square meter every 3 weeks. Patients showing disease progression, whether in the maintenance or observation group, received a second round of CAPOX-B. Those without progression were continually monitored. After a median 48-month observation period, results showed a significant 3.2-month extension in progression-free survival, PFS, in the maintenance group, reaching 11.7 months compared to 8.5 months in the observation group. This improvement persisted even considering subsequent treatments after the first progression. A trend towards enhanced median overall survival at 26 months versus 22 months was observed, with no significant decline in quality of life in the maintenance group, indicating the efficacy and tolerability of capecitabine in combination with other agents. Notably, the main side effect was an increased incidence of hand-foot syndrome. In conclusion, the CAIRO-3 study demonstrates the effectiveness of maintenance treatment, with capecitabine and bevacizumab, following CAPOX-B induction, in managing metastatic colorectal cancer, while preserving patients' quality of life. Another study, known as the MOMA trial, focused on metronomic low-dose chemotherapy combined with bevacizumab, for patients with metastatic colorectal cancer. The MOMA trial aimed to evaluate the efficacy of adding metronomic low-dose chemotherapy to bevacizumab, compared to using bevacizumab alone, as a maintenance therapy, following an initial 4-month period of induction therapy, with FOLFOXIRI and bevacizumab. In this phase 2 study, patients with unresectable metastatic colorectal cancer were divided into 2 groups. One group received up to 8 cycles of FOLFOXIRI plus bevacizumab, followed by bevacizumab alone. The other group followed the same initial regimen, but then continued with a combination of bevacizumab and metronomic oral chemotherapy, capecitabine at a dose of 500 mg 3 times per day, and cyclophosphamide at 50 mg per day, until the disease progressed. The trial included 232 patients across 16 centers in Italy, with a majority having tumors with KRAS, or BRAF mutations. At a median follow-up of 47.8 months, the study found that the median progression-free survival was 10.3 months, for the group receiving the combination therapy, and 9.4 months for the group receiving bevacizumab alone. However, there were no significant differences in overall survival between the 2 groups, with a median overall survival of 22.5 months for the combination therapy group, and 28 months for the bevacizumab alone group. The conclusion drawn from the MOMA trial was that the addition of metronomic low-dose chemotherapy to maintenance therapy with bevacizumab did not markedly enhance the progression-free survival of patients with metastatic colorectal cancer. Let's turn our attention to liver cancer, specifically hepatocellular carcinoma or HCC. Recent multicentric retrospective studies suggest that capecitabine may be a safe and effective option for patients with HCC. These studies have focused on the efficacy of metronomic low-dose capecitabine as a second-line treatment. Researchers examined data from HCC patients who were either unresponsive or intolerant to sorafenib treatment. They compared those who received metronomic low-dose capecitabine with those who were given best supportive care, the results indicated that the median progression-free survival was 3.1 months for patients treated with capecitabine. Additionally, the median overall survival was more favorable for the capecitabine group at 12.0 months, compared to 9.0 months for patients receiving best supportive care. Moreover, the outcomes of a univariate Cox regression model, which was not weighted, showed a 46% reduction in the risk of death for patients on capecitabine, when juxtaposed with patients who received only best supportive care. Even after adjusting for potential confounders, the risk of death remained substantially reduced by 45%. As anticipated, metronomic low-dose capecitabine appears to be well tolerated, presenting minimal side effects. It emerges as a viable second-line treatment for HCC, particularly when considering the management of adverse events. The regimen shows potential anti-tumor activity, warranting further exploration in phase 3 studies. In a recent small-scale study, there's growing interest in the use of classical metronomic low-dose chemotherapy, combined with immunotherapy for treating advanced hepatocellular carcinoma, HCC. Specifically, the study looked into low-dose nivolumab and metronomic oral cyclophosphamide. Let's examine the approach and the findings in detail. The study administered low-dose nivolumab at 20 mg biweekly, along with daily oral metronomic low-dose cyclophosphamide at 50 mg. The aim was to assess the potential suppression of regulatory T cells or Tregs by cyclophosphamide, and to determine if low-dose nivolumab could still be effective for immunogenic cancers. A group of 15 patients received this second-line treatment regimen. The outcomes were noteworthy, with a response rate of 53%, and a clinical benefit observed in 73% of the participants. Drawing conclusions from these findings, it appears that the combination of immune checkpoint inhibitors, with metronomic low-dose chemotherapy cyclophosphamide, could be both feasible and effective. Moreover, this approach seems to offer a reduction in toxicity and cost. Interestingly, patients with HCV infection, or those with only lung or lymph node metastases, responded more favorably to the treatment. The study highlights the need for further research into the immune-modulating mechanisms of metronomic oral cyclophosphamide, and the biologically effective dose of nivolumab. Additionally, it underscores the importance of clinical trial design, and the exploration of biomarkers, to enhance treatment efficacy and patient outcomes. Advanced pancreatic cancer presents as an aggressive and rapidly fatal illness. Historically, there has been minimal improvement in the survival rates of patients with metastatic disease, despite various therapeutic efforts. Conventional treatment strategies utilizing maximum tolerated dose have yielded limited benefits. It has been demonstrated that tumor cells resistant to chemotherapy at standard dose may still respond positively to lower dose therapy. Prior investigations have explored the potential of continuous infusion 5-fluorouracil and leucovorin in combination with nab-paclitaxel and oxaliplatin for managing pancreatic adenocarcinoma. Notably, 5-fluorouracil, when administered as an extended low-dose infusion, exhibits anti-angiogenic property, and demonstrates synergy with bevacizumab. Similar synergistic effects have been observed with bevacizumab and nab-paclitaxel in the context of breast cancer treatment. Dr. Issakoff from UCLA conducted a retrospective analysis, involving 65 patients afflicted with advanced, inoperable pancreatic ductile adenocarcinoma. These patients received treatment involving 5-fluorouracil as a prolonged infusion, in conjunction with weekly low-dose leucovorin, nab-paclitaxel, and oxaliplatin. This therapeutic approach combined low-dose and continuous metronomic chemotherapy with conventional anti-VEGF therapy. The treatment protocol involved administering 5-fluorouracil, at a daily dose of 180 mg/m2, over a span of 14 days. Additionally, leucovorin was administered intravenously, at a dosage of 20 mg/m2, while nab-paclitaxel was given at 60 mg/m2 through a 30-minute infusion. Oxaliplatin was administered intravenously, at a dosage of 50 mg/m2 over a 60-minute infusion on days 1, 8, and 15 within each treatment cycle. Bevacizumab was administered intravenously, at a dose of 5 mg/kg over 30 minutes on days 1 and 15. These treatment cycles were repeated every 28 to 35 days. The patient cohort consisted of 42 women and 23 men, with a median age of 59 years. Among them, 46 patients were diagnosed with stage 4 disease. The UCLA study's results are quite promising. To start, there's an impressive overall response rate of 49%. Among the 28 patients who had previously undergone treatment, 15 responded well to the therapy. Out of the 52 patients who began the study with elevated CA199 levels, 21 experienced a notable reduction of 90% or more in their CA199 levels. This particular group achieved an objective response rate of 71%, and a median survival period of 27 months. For the entire study population, the median survival duration reached 19 months, with a significant 82% of patients surviving for at least 12 months. Unfortunately, 30 patients had to discontinue treatment due to disease progression, and an additional 22 had to halt treatment due to toxicity. Tragically, one patient passed away while still undergoing therapy. In conclusion, the UCLA investigation into the effects of a Metronomic, low-dose chemotherapy regimen has revealed substantially improved response rates, and enhanced survival, when compared to the commonly used conventional dosing schedules in therapy. The combination of Metronomic low-dose chemotherapy, with anti-angiogenic therapy, not only proved to be safe, but also highly effective. As the old saying goes, don't compare apples to oranges, and it's true that comparing outcomes from different trials may not always be wise. Nevertheless, we can gain insights from various studies. While it's not always straightforward to make comparisons between different treatments, I can offer a general perspective on how Metronomic FOLFOX stacks up against standard care treatments. Among the patients who received Metronomic FOLFOX, 82%, 53 patients, survived for 12 months or more, and the overall median survival for this group was 19 months. This performance outperforms two standard care treatments, FOLFIRINOX, which has a median survival of 11.1 months, and gemcitabine nab-paclitaxel, which has a median survival of 8.5 months. Dr. Sahai and their team conducted a follow-up study based on Dr. Isakov's research, utilizing a similar but slightly reduced dosage of Fablox. This study aimed to assess tolerability in the Phase 1 multicenter single-arm investigation into the Metronomic 5-FU regimen, combined with nab-paclitaxel, bevacizumab, leucovorin, and oxaliplatin, or Fablox, in newly diagnosed metastatic pancreatic cancer patients. Notably, the dosages of oxaliplatin and nab-paclitaxel were intentionally decreased compared to those used in Dr. Isakov's study, with the goal of further minimizing toxicity while preserving effectiveness. In this Phase 1 clinical trial, a total of 12 previously untreated patients diagnosed with pancreatic cancer were administered the following treatment regimen in each 28-day cycle. 5-fluorouracil at a dosage of 180 mg/m2 per day given continuously from days 1 to 14. Nab-paclitaxel at a dosage of 75 mg/m2. Leucovorin at a dosage of 20 mg/m2. Oxaliplatin at a dosage of 40 mg/m2 administered on days 1, 8, and 15. bevacizumab at a dosage of 5 mg/kg administered intravenously on days 1 and 15. The findings of this study suggest that the Fablox regimen is viable and well tolerated in newly diagnosed pancreatic cancer patients with good organ function and no prior systemic chemotherapy. The most frequently observed adverse events of grade greater than or equal to 3 were abdominal pain, fatigue, mucositis, and decreased neutrophil count. The objective response rate was 33%, and the median progression-free survival and overall survival were 5.6 and 9.9 months, respectively. In conclusion, Fablox appears to be a feasible and well-tolerated treatment option for patients newly diagnosed with pancreatic cancer. However, the preliminary efficacy data do not provide a definitive conclusion. Notably, the Fablox regimen in this study exhibited a similar tolerability profile to the combination therapy regimen described by Isikoff, where 34% of patients discontinued treatment due to toxicity. This study showed a comparable rate, with 33% of patients treated with Fablox discontinuing due to adverse events. While phase I results demonstrate a safe profile for Metronomic Fablox in newly diagnosed pancreatic cancer patients, further investigation in a phase II trial is warranted, due to the limited number of patients in this study, and preliminary efficacy data remain inconclusive. Dr. Hui from Seattle conducted a retrospective analysis of treatment regimens involving weekly low-dose chemotherapy, with sequential gemcitabine, oxaliplatin, and irinotecan, for patients diagnosed with biopsy-proven metastatic pancreatic cancer. The study encompassed 30 patients, who had been confirmed to have metastatic pancreatic cancer, and all the Metronomic chemotherapy treatments were administered on a weekly basis. Within Dr. Chu's group, the median overall survival reached 18.9 months from the moment of diagnosis, and 14.2 months from the initiation of Metronomic low-dose weekly chemotherapy. Interestingly, 27% of patients surpassed the 30-month, and notably, 3 individuals in this cohort achieved an exceptional survival period of over 5 years. Combining the maximum tolerated dose chemotherapy with subsequent Metronomic chemotherapy, also known as a chemo switch, has demonstrated its ability to enhance the anti-tumor effect. The Metronomic MTD chemo switch model provides evidence of this approach's effectiveness, wherein MTD chemotherapy is followed by a multi-targeted, low-dose maintenance treatment. Animal studies have illustrated the favorable outcomes of this MTD and Metronomic chemotherapy chemo switch. In a multi-center phase II study led by Dr. Belmont, the study explored the effectiveness of MTD gemcitabine when combined with Metronomic capecitabine, and the multikinase inhibitor sorafenib, for treating metastatic renal cell carcinoma. The study recruited patients from 8 centers in Spain, who had confirmed metastatic renal cell carcinoma with clear cell histology. The treatment plan included administering intravenous gemcitabine, at 1000 mg per square meter, oral capecitabine, at 500 mg per square meter twice daily, and oral sorafenib, at 400 mg twice daily for 6 cycles, followed by sorafenib monotherapy. Let's delve into the findings of this study, focusing on the 44 participants. Their median progression-free survival lasted 11.1 months. Among them, 20 individuals partially responded to the treatment, while 17 maintained stable disease. In terms of safety, it's important to note that most patients experienced mild adverse events. However, some individuals did encounter more severe grade 3 adverse events, including fatigue or asthenia, hand-foot skin reactions, mucositis, diarrhea, and infections. Comparing these results to previous treatments, like gemcitabine, capecitabine, or sorafenib monotherapy, for metastatic renal cell carcinoma patients, the combination treatment used in this study demonstrated superior progression-free survival and response rates. This supports the idea of combining treatments, often referred to as the chemo switch approach. These findings offer initial confirmation of the synergistic effects associated with the chemo switch concept, observed in preclinical studies, and warrant further investigation. Let's look into the outcomes of a study involving 45 patients diagnosed with metastatic renal cell carcinoma. The study aimed to explore the effects of an anti-inflammatory treatment approach, combined with metronomic low-dose chemotherapy. Notably, 42% of these patients had previously undergone systemic treatments. The treatment regimen is daily doses of etoricoxib, a selective COX-2 inhibitor, at a dosage of 60 mg, commencing on day 1. Simultaneously, they were administered pioglitazone, at a dose of 60 mg, starting on day 1 as well. Additionally, patients received low-dose interferon alpha 4.5 million units through subcutaneous injections, 3 times a week. Low-dose capecitabine, at 1 gram per square meter, was taken orally, twice daily for 14 days. This treatment cycle was repeated every 3 weeks. Examining the study's findings, there's a noteworthy objective response rate of 35%, and the median overall survival extended to 26.9 months, while the median progression-free survival amounted to 7.2 months. It's important to note that the 5-year overall survival rate reached 18%. However, it's worth mentioning that hand-foot syndrome was documented in 16 patients, affecting around 36% of the participants. In summary, this investigation suggests that the combination of an anti-inflammatory treatment approach and low-dose chemotherapy has demonstrated promising outcomes for individuals with metastatic renal cell carcinoma. The prognosis for individuals with glioblastomas remains grim. Despite the adoption of multifaceted treatment strategies, glioblastomas prove to be relentless, yielding an exceptionally poor prognosis. The prevailing standard of care involves concurrent chemoradiotherapy that utilizes temozolomide, followed by temozolomide chemotherapy, which has demonstrated a substantial extension in survival. Nevertheless, even with the most effective management of malignant gliomas, recurrences frequently arise within the initial 2 years. A pivotal development in understanding malignant glioma pathology is the recognition of angiogenesis as a pivotal characteristic. Malignant gliomas, including glioblastomas, are counted among the most highly vascularized human tumors. Consequently, targeting tumor angiogenesis has become a central therapeutic focus in the management of glioblastoma. Metronomic low-dose chemotherapy serves as an approach that not only targets actively dividing tumor cells and endothelial cells, but also minimizes treatment-related toxicity. This regimen has demonstrated potent anti-angiogenic effects. Let's look into clinical trial data to thoroughly assess the effectiveness of metronomic treatment for glioblastomas. Exploring alternative dosing schedules of temozolomide holds the potential to enhance survival rates in newly diagnosed glioblastoma patients. This randomized phase 2 study, conducted by MSKCC, aimed to assess the efficacy of 2 distinct temozolomide regimens for adjuvant treatment in this patient population. In this study, adult patients with newly diagnosed glioblastoma were randomly divided into 2 groups. One group received standard radiotherapy, concurrently with daily temozolomide, followed by 6 adjuvant cycles of dose-dense temozolomide, 150 mg per square meter on days 1 to 7 and 15 to 21. The other group received metronomic temozolomide, 50 mg per square meter administered continuously on a daily basis. Additionally, maintenance doses of retinoic acid were administered until tumor progression. A total of 85 eligible patients participated in the study, with 42 assigned to the dose-dense arm, and 43 to the metronomic arm. The 1-year survival rate was 80% for the dose-dense group, and 69% for the metronomic group, with median overall survival times of 17.1 months, and 15.1 months, respectively. The most frequent adverse effects included myelosuppression, leukopenia, neutropenia, and thrombocytopenia, and elevated liver enzyme levels. Pseudoprogression was observed in 37% of assessable patients, which may have influenced the estimates of progression-free survival. Both dose-dense and metronomic temozolomide regimens were well tolerated, with manageable toxicity levels. The dose-dense regimen, in particular, shows promise, evidenced by its 1-year survival rate of 80%. Both dose-dense and metronomic temozolomide regimens are comparable with the standard protocol of STOOP. A Phase 2 study took place at the Dana-Farber Cancer Center to examine the feasibility of using anti-angiogenic metronomic low-dose chemotherapy regimen in adults with recurrent malignant gliomas. This regimen included administering oral etoposide daily for 21 days, followed by oral cyclophosphamide for 21 days in each 6-week cycle. Furthermore, they administered thalidomide and celecoxib continuously throughout the entire cycle. The dosage for oral etoposide was 35 mg/m2 per day, with a maximum of 100 mg daily. Oral cyclophosphamide was given at a daily dose of 2 mg/kg, not exceeding 100 mg daily. Thalidomide started at a dose of 50 to 200 mg orally at bedtime, based on the treating physician's discretion, and increased by 50 mg per week, up to a maximum of 1,200 mg daily. Celecoxib began at a dose of 200 mg twice daily and was raised to 400 mg twice daily for patients weighing more than 50 kg. 48 patients participated in this study, comprising 15 females and 33 males. Among them, 28 patients were diagnosed with glioblastoma multiforme, while 20 had anaplastic gliomas. The median age of the participants was 53 years. The treatment was reasonably well tolerated, despite the patients being heavily pre-treated. Only 2% of patients exhibited a partial response, 9% showed a minor response, 59% maintained stable disease, and 30% experienced progressive disease. For GBM patients, the median progression-free survival lasted 11 weeks, with a 6-month progression-free survival rate of 9%, and a median overall survival of 21 weeks. In contrast, anaplastic glioma patients had a median progression-free survival of 14 weeks, progression-free survival rate of 26%, and a median overall survival of 41.5 weeks. Despite some patients showing a response, this 4-drug, oral metronomic regimen, did not significantly enhance overall survival in this heavily pre-treated patient cohort, which was generally ineligible for conventional protocols. While metronomic low-dose chemotherapy may not benefit patients with advanced disease, it may be worthwhile to explore further studies, combining metronomic low-dose chemotherapy with more potent anti-angiogenic agents, in patients with less advanced disease. The 4-drug oral metronomic regimen did not result in a significant improvement in overall survival for this heavily pre-treated patient group. However, within this cohort, which often didn't qualify for standard treatments, Dana-Farber researchers did identify a subgroup of responders. An instructive illustration of this response is evident in MRI images, showcasing the favorable reaction to the anti-angiogenic regimen. These images correspond to a 64-year-old woman, who had recurrent anaplastic astrocytoma, and had previously undergone surgery, radiation therapy, temozolomide treatment, PCV therapy, comprising procarbazine, CCNU, and vincristine, as well as temsirolimus and fenretinide therapies. Dr. Perry, from Sunnybrook's Cancer Center in Canada, conducted a multi-center, Phase 2 investigation to examine the use of Metronomic continuous low-dose temozolomide for recurrent malignant brain tumors, glioblastoma multiforme or GBM. They enrolled patients with malignant glioma, whose disease progressed after the standard temozolomide regimen, of 150 to 200 mg per square meter over 5 days, within a 28-day cycle for 3 or more cycles. The patients were categorized based on tumor type: anaplastic glioma group A, or malignant glioblastoma multiforme group B. 91 malignant brain tumor patients were divided into 3 groups: early, B1, extended, B2, and re-challenge, B3, based on when their progression occurred during adjuvant therapy. All patients were administered continuous low-dose temozolomide at 50 mg per square meter per day for up to 1 year or until progression was observed. The results showed that out of 120 patients, 116 were eligible for assessing efficacy. In patients with anaplastic glioma in Group A, the 6-month PFS was 35.7%, and the 1-year survival rate was 60.7%. For malignant recurrent glioblastomas patients in Group B, the 6-month progression-free survival rates were as follows: B1 group, 27.3%, B2 group, 7.4%, and B3 group, 35.7%. 1-year survival rates from the time of study entry were 27.3%, 14.8%, and 28.6% for the B1, B2, and B3 groups, respectively. The most common severe non-hematologic side effects were nausea, vomiting, 6.7%, and fatigue, 5.8%. Severe hematologic side effects were rare. In conclusion, re-challenge with continuous low-dose temozolomide at 50 mg per square meter per day is a valuable treatment option for patients with recurrent malignant brain tumors. Patients who experience progression within the first 6 cycles of conventional adjuvant temozolomide therapy, or after a treatment-free interval, derive the most benefit from this therapy. A team of cancer specialists from South Korea conducted a Phase 2 trial to investigate the efficacy of low-dose continuous, Metronomic, temozolomide for recurrent glioblastomas, GBMs. The study focused on patients with GBMs, who had developed resistance to previous TMZ treatments, and had undergone disease recurrence or progression following standard post-surgery radiotherapy. During the trial, a total of 38 patients were administered a daily dose of temozolomide at 50 mg/m2. The findings revealed a 6-month progression-free survival, PFS, rate of 32.5%, and a 6-month overall survival, OS, rate of 56.0%. Notable adverse events encompassed 1 patient experiencing neutropenia, with 3 patients encountering thrombocytopenia, and 3 others manifesting elevation in liver enzyme levels. 4 participants had to terminate their involvement in the study due to side effects, such as persistent hematological disorders, cryptococcal infection, and cellulitis. Nevertheless, despite these challenges, the study ascertained that the patients maintained a well-preserved quality of life, in comparison to their state prior to treatment initiation. The Metronomic temozolomide regimen demonstrated efficacy in managing recurrent glioblastomas even among cases resistant to conventional temozolomide therapy, while maintaining an acceptable level of toxicity. Cancer researchers at Beth Israel Deaconess Medical Center, Harvard Medical School, embarked on an exploratory study, looking into the effects of lower-dose temozolomide, and investigating the mechanisms of action associated with this approach. In this Phase 1 study, they utilized Metronomic temozolomide, at either 25 or 50 mg per square meter per day continuously, administered in 42-day cycles. The research also encompassed complementary investigations, such as arterial spin labeling MRI to evaluate tumor blood flow, analysis of matrix metalloproteinase 2, MMP2, and MMP9 activities in cerebrospinal fluid, to serve as proxies for tumor angiogenesis and invasion, and the measurement of cerebrospinal soluble interleukin-2 receptor alpha levels, as an indicator of immune modulation. The study enrolled 9 participants, and observed toxicity primarily consisted of mild hematological and gastrointestinal side effects, with only one patient experiencing a reversible elevation in liver enzyme levels. Tumor blood flow exhibited variability among subjects and over time, with 2 individuals displaying a temporary increase, followed by a decline below baseline, while another showed a gradual reduction in blood flow. MMP2 activity was found to correlate with overall survival. The baseline interleukin-2 receptor level displayed an inverse relationship with the time from initial diagnosis to the first progression, suggesting that individuals with higher interleukin-2 receptor levels may have more aggressive disease. However, when treated with metronomic temozolomide, they experienced extended survival, possibly attributable to drug-induced alterations in T-cell composition. In conclusion, metronomic temozolomide exhibits efficacy in combating recurrent malignant gliomas by modifying blood flow, impeding invasion, and modulating anti-tumor immune responses. Italian cancer researchers recently shared their insights into using metronomic low-dose TMZ for recurrent GBM with wild-type IDH, which is associated with a challenging prognosis. They conducted a retrospective review of all patients treated between September 2013 and March 2021. The study included those who had initially received the STOOP protocol as first-line therapy, experienced relapse after first or subsequent treatments, and underwent treatment with a continuous, metronomic TMZ schedule, 50 mg per square meter. The study enrolled 120 patients with a median follow-up of 15.6 months, and a median age of 59 years. Notably, 62% of patients had MGMT methylation. These patients had undergone a median of 2 prior lines of treatment. Results showed that 2% had a partial response, 40% maintained stable disease, while 57% had progressive disease. Median overall survival from the initiation of metronomic TMZ was 5.4 months, and progression-free survival was 2.6 months. Univariate analysis revealed that patients with MGMT methylated tumors had a median overall survival of 5.6 months, compared to 4.4 months for those with unmethylated tumors. Hematological toxicities, including lymphopenia, 10%, and thrombocytopenia, 3%, were the most common adverse events. In conclusion, rechallenging patients with metronomic TMZ is a well-tolerated option for recurrent GBM, even in those with prior treatment history. Notably, patients with MGMT methylated disease derive the greatest benefit from this treatment approach. Now, allow me to provide you with some fundamental insights into GBM survival rates. A group of leading experts in neurology and oncology, at the Walton Centre in the UK, recently compiled their research findings on glioblastoma survival, in the era of modern chemotherapy and radiation therapy. It's worth noting that they have verified certain biomarkers, associated with enhanced overall survival, OS, and progression-free survival, PFS, in glioblastoma cases, such as MGMT methylation status, and IDH1 gene mutations. The study revealed a median OS of 12 months and a median PFS of 8 months as a whole. Survival rates at the 2-year, 3-year, and 5-year marks were 18%, 9%, and 6%, respectively. Through Kaplan-Meier survival analysis, they unveiled the following outcomes based on MGMT and IDH1 status. MGMT, methylated, and IDH1 mutated, demonstrating an impressive OS of 66.8 months and a PFS of 16.9 months. MGMT, methylated, and IDH1 unmutated, reflecting an OS of 15.5 months and a PFS of 9.4 months. MGMT, unmethylated, and IDH1 unmutated, indicating an OS of 11.1 months and a PFS of 6.3 months. These findings offer valuable insights into the factors influencing survival in glioblastoma patients undergoing chemoradiotherapy. Metronomic low-dose chemotherapy, known for providing modest patient benefit, raised questions about its potential to reverse disease progression in patients who had failed bevacizumab therapy. To address this uncertainty, a Phase 2 study was conducted at Duke University, specifically focusing on recurrent GBM patients who had experienced progression after prior bevacizumab treatment. The study aimed to assess the efficacy of combining metronomic temozolomide or etoposide with bevacizumab. In an open-label, 2-arm trial, 23 patients received bevacizumab, 10 mg per kilogram, every 2 weeks, in combination with either daily oral etoposide, 50 mg per square meter, for 21 consecutive days each month, or daily temozolomide, 50 mg per square meter. The primary endpoint was 6-month progression-free survival, with secondary objectives including safety and overall survival. Regrettably, both the etoposide and temozolomide arms of the study were terminated during interim analysis due to insufficient anti-tumor activity. Radiographic responses were absent, and although stable disease was achieved in 52% of patients, 6-month progression-free survival was a mere 4.4%, with a median of 7.3 weeks. Notably, the study reported only one severe adverse event, which was reversible neutropenia. In summary, the administration of metronomic etoposide or temozolomide, with bevacizumab, to recurrent GBM patients, who had progressed on prior bevacizumab therapy, proved to be ineffective. This patient population urgently requires alternative treatment strategies. Stereotactic radiosurgery and stereotactic radiotherapy are increasingly being used to treat brain tumors. These methods offer more precise irradiation of brain lesions while sparing healthy brain tissue, in contrast to whole-brain radiation therapy. However, due to higher radiation doses to the tumor and surrounding normal brain tissue, both stereotactic radiosurgery and stereotactic radiotherapy carry the risk of a significant side effect, known as focal radiation necrosis of the brain. The estimated incidence of radiation necrosis falls between 7% and 24%, typically occurring around 1 year after radiotherapy. Symptoms may include neurological deficits, cognitive decline, increased intracranial pressure, and seizures. Currently, corticosteroids are commonly used as the first-line treatment for symptomatic patients not suitable for neurosurgical debridement. In 2014, Dr. Tai introduced bevacizumab as an effective therapeutic option for focal radiation necrosis of the brain. Bevacizumab is typically administered at a dose of 5 to 10 mg/kg every 2 weeks. Gordon found that significantly lower doses down to 0.3 mg/kg reduced serum vascular endothelial growth factor concentrations below detectable levels. Based on these findings, Dr. Jens Tegit and his team began using a low-dose bevacizumab regimen, which includes a 400 mg 4-loading dose, followed by 100 mg for every 4 weeks, to treat patients diagnosed with symptomatic focal radiation necrosis of the brain, who were not suitable candidates for neurosurgical debridement. Other research groups have also demonstrated the efficacy of low-dose bevacizumab, including regimens of 1 mg/kg and 3 mg/kg. Now, let's take a closer look at the research conducted by Dr. Jens Tegit's group. In their single-center retrospective case series in Belgium, they examined the effectiveness of a low-dose bevacizumab regimen, which consists of a 400 mg loading dose, followed by 100 mg every 4 weeks, in patients with focal radiation necrosis of the brain. The study included a total of 13 patients. The results are remarkable, with 12 of them experiencing improvements in their existing clinical symptoms, and all patients showing a reduction in edema volume on MRI scans. No clinically significant treatment-related adverse effects were observed. These preliminary findings suggest that the fixed low-dose bevacizumab regimen, with a 100 mg dose every 4 weeks, can be a well-tolerated and cost-effective alternative treatment option for patients with focal radiation necrosis of the brain, warranting further investigation. Now, let's turn our attention to another type of brain tumor, medulloblastoma. Medulloblastoma recurrence poses a grim prognosis, and lacks a standardized salvage treatment. To assess the response rate in pediatric patients with recurrent medulloblastoma, researchers embarked on a Phase 2, investigator-initiated, multicenter, non-randomized controlled trial, known as the Medulloblastoma European Multitarget Metronomic Anti-Angiogenic Trial, or MEMAT, in short. In this trial, 40 patients with relapsed or refractory medulloblastoma, under 20 years old, at the time of initial diagnosis, and without a ventricular peritoneal shunt, were evaluated between April 1, 2014, and March 31, 2021. The treatment involved daily oral administration of thalidomide, fenofibrate, celecoxib, and alternating 21-day cycles of low-dose, metronomic, oral etoposide, and cyclophosphamide. Additionally, intravenous bevacizumab, and intraventricular therapy, with alternating etoposide and cytarabine, were administered. Out of the 40 patients, with a median age of 10 years at the start of treatment, 57% achieved disease control at the 6-month mark, and 18 patients, 45.0%, responded to the treatment. Median overall survival was 25.5 months, and median progression-free survival was 8.5 months. Generally, the treatment was well tolerated, with moderate to severe adverse events including myelosuppression, infections, seizures, and headaches. In conclusion, the MEMAT combination regimen, which is predominantly administered orally, well tolerated, displayed promising activity in patients with recurrent medulloblastoma who had previously received irradiation. Given these results, and the meaningful clinical benefit observed in a challenging-to-treat patient population, further evaluation of this combination is warranted. Meningeal carcinomatosis, a rare complication in solid tumors like breast cancer, lacks defined management guidelines. One hypothesis is that angiogenesis plays a role in neoplastic meningitis, making metronomic low-dose chemotherapy a potential treatment option to inhibit tumor angiogenesis. Doctors from the University Hospital of Modena, Italy, present a case of successful treatment for symptomatic leptomeningeal carcinomatosis from breast cancer, using low-dose capecitabine. The patient received metronomic treatment, which offered long-term clinical benefits with minimal toxicity. The patient, a 57-year-old postmenopausal woman, had stage 4 breast cancer, with multiple bone and lung metastases. The breast cancer was hormone receptor positive, HER2 negative, and had a high proliferative rate. Various treatments were administered, including hormonal therapy and radiotherapy, but progression occurred. A metronomic dose of capecitabine, 500 mg 3 times a day, was initiated after the patient experienced a seizure, and was diagnosed with leptomeningeal lesions on a brain and spinal cord MRI. Metronomic capecitabine led to a gradual reduction in tumor marker, and showed a decrease in leptomeningeal lesions and tumor vasculature on an MRI performed after 6 months. Adverse effects were minimal, and the patient's leptomeningeal progression-free survival was 23 months. The patient no longer experienced seizures, and maintained a good performance status. This case report is significant, as it demonstrates a long-term response to metronomic capecitabine treatment for leptomeningeal metastasis, highlighting its potential as a viable therapeutic option. Metronomic low-dose chemotherapy has also shown promise in treating leptomeningeal metastases from HER2-positive breast cancer. The prognosis for this condition is notably grim, and there is currently limited high-quality evidence on effective treatment options. Dr. Chi from mainland China shares a case involving a 50-year-old woman with HER2-positive breast cancer and leptomeningeal metastases. In a pioneering study, the patient received a combination treatment approach that included pyrotinib-targeted therapy, 400 mg orally daily, metronomic vinorelbine, 40 mg orally 3 times a week, and occasional intrathecal methotrexate, 10 mg, with infrequent and irregular use due to poor compliance. Remarkably, the patient experienced a positive response to this treatment regimen, lasting for 16 months. Moreover, she reported a significant improvement in her quality of life. The combination of pyrotinib-targeted therapy with metronomic low-dose chemotherapy appears to hold promise as an effective approach for managing HER2-positive breast cancer with leptomeningeal metastases. Angiogenesis is a crucial process in the spread of soft tissue sarcomas. Metronomic chemotherapy primarily focuses on endothelial cells. Hence, metronomic low-dose etoposide may effectively control the progression of soft tissue sarcomas, despite the limited efficacy of etoposide at its maximum tolerated dose in these tumors. A study conducted in France took an innovative approach, by using etoposide as an anti-angiogenic agent, in the treatment of soft tissue sarcomas. The study involved a review of the medical records of 26 metastatic soft tissue sarcoma patients who received treatment at Institut Burgony in Bordeaux. These patients were administered metronomic etoposide at a daily dose of 100 mg orally for 21 consecutive days, with treatment cycles repeated every 4 weeks. The patients, with a median age of 49, had mostly undergone prior treatments with doxorubicin and ifosfamide. The findings of the study revealed that 1 patient, 4%, achieved a partial response, and 11 patients, 42%, experienced stable disease for more than 24 weeks. The 6-month progression-free survival rate was 42%, and the 1-year rate was 23%. In terms of overall survival, the 6-month rate was 69%, and the 1-year rate was 31%. Unfortunately, 2 patients encountered grade 4 febrile neutropenia, and regrettably, one of them succumbed to sepsis. In summary, the use of metronomic etoposide demonstrated significant clinical activity in this cohort of soft tissue sarcoma patients. Nonetheless, further prospective studies are required to pinpoint the patients who would derive the most benefit from this treatment approach. Treating relapsed osteosarcoma remains a clinical challenge, with no established standard therapy. Unfortunately, the prognosis is grim, with a median overall survival of only 8 months. Effective systemic treatments are greatly needed for patients with metastatic osteosarcoma. Angiogenesis, a critical factor in tumor growth and metastasis, is a key player in osteosarcoma. Low-dose chronic, oral etoposide administered metronomically has shown promise in various recurrent cancers, including soft tissue sarcoma, with manageable side effects. Considering this, oral metronomic etoposide holds potential for treating metastatic osteosarcoma. Researchers from Gustave Roussy Cancer Institute in France conducted a retrospective study on patients treated with oral etoposide. The patients received oral metronomic etoposide at either 25 mg 3 times daily, for 3 weeks out of 4, one cycle lasting 28 days, or 25 mg twice daily, for 2 out of 3 weeks. A total of 37 patients were eligible for the analysis. At 4 months, the progression-free rate was 40.3%, with 11% achieving a partial response, and 35% experiencing stable disease, resulting in a disease control rate of 46%. Median progression-free survival was 3.1 months, while median overall survival reached 9.8 months. Importantly, the treatment's toxicity profile was manageable, with only 13% experiencing hematological toxicities, and no severe non-hematological toxicities reported. In summary, oral metronomic etoposide demonstrated effective palliative benefits, with manageable side effects, for patients with progressive metastatic osteosarcoma. This talk discusses the emerging potential of metronomic chemotherapy, a treatment approach involving frequent administration of low-dose drugs, without extended breaks, in the context of cancer management. Metronomic chemotherapy is gaining recognition as an alternative strategy for cancer patients experiencing drug resistance or toxic side effects. It entails the continuous administration of lower drug doses. Metronomic chemotherapy's effectiveness stems from its ability to control tumors through multiple mechanisms, including inhibiting angiogenesis, the formation of new blood vessels, suppressing tumor cell growth, and indirectly boosting the body's anti-tumor immune response. Metronomic chemotherapy is currently more commonly used in palliative care settings, rather than as a primary treatment. However, ongoing research is exploring its potential in treating various tumor types, by effectively addressing angiogenesis and tumor heterogeneity. Metronomic chemotherapy was initially developed to overcome resistance to conventional chemotherapy, making it a valuable tool in cancer management. As different tumor types may respond differently to metronomic regimens, further investigation is needed. Research should focus on identifying the most effective chemotherapeutic drugs, based on tumor type, determining optimal drug dosages, whether used alone or in combination, and refining the timing of drug administration. Given the numerous possible combinations of metronomic chemotherapy, with targeted therapy, immune checkpoint inhibitors, or even alternating with conventional maximum tolerated dose chemotherapy, continued exploration and research in this field are essential. In summary, metronomic chemotherapy holds promise as an innovative approach to cancer treatment, with its ability to target tumor growth, stimulate the immune system, and potentially overcome drug resistance. However, further studies are needed to optimize its use for different cancer types and refine treatment protocols. That concludes today's discussion on metronomic chemotherapy. Thank you for tuning in, and goodbye.